Okay. Hello everyone. Very, very good evening to all of you. I am Dr. Sanchit Bajpai. I am also the ENT faculty at PW MedEd, and we will be dealing with a lot of clinical image-based questions as far as my subject is concerned, as far as ENT and head and neck surgery is concerned. And whenever this visual images come into play, right, ENT is one subject which has got a lot of images, right? So if we capture these images inside our head, if we turn on, all these signs and symptoms, if we relate to these images, it becomes a piece of cake to actually understand the diagnosis of that particular lesion, right? So I have done the radiological imaging part where I've discussed the important X-rays, CT scans as well as MRIs already, and that is already available on the PW MedEd channel, okay? So I'm not going to discuss the radiological imaging because that I've solely discussed the 20 important scans. I've done it separately. What I'm going to do in this particular segment, I'm going to go into particular variety of lesions, okay, of ear, nose, throat, oral cavity, pharynx and larynx. We are going to see the images, and with those images, we are going to have certain allied questions which have come in your exams. We'll cover a lot of questions around those images. I'm going to tell you what all types of questions are asked in those images, and then we are going to finish off that particular chapter in just one image. This is how we are going to do. So there is a lot of images. I've got around 75-80 images to show you. And we are going to go into larynx, oral cavity and pharynx, nose, ear, and some operative procedures as well as instruments. So we are going to deal a lot of things in this particular segment, and you need to sit tight so that, you can understand all of these things. Now, I would welcome all of your comments in the comment box. Whenever you are having any problem, you can straight away put your question over in the comment box. I'll straight away answer that question. Okay? Very good evening, Debaki. Very good evening, Gautam. Good to see you all, right? So let's start. What are these image-based question series as far as ENT is concerned? Okay, fine. Now, what exactly is this image? First, let's figure out this image. And inside this image, there are a lot of questions that they ask as allied questions, okay? So what is this? This is a video laryngoscopy image, which is showing the inside or the inlet of the larynx, right? So what we are seeing, हम क्या देख रहे हैं? We are seeing the inside of the larynx or the inlet of the larynx. अब इसी में let's label certain important parts which are asked as questions, that what all parts can you see inside here? Okay, so what can you see inside here? First, let's start from here. You can see this kind of a projected part, right? It's coming out. This is your epiglottis. Okay, so many of the times they ask these questions as they will label a part and they will ask you, what is this? This is the epiglottis which is projected out. The epiglottis and the tongue. So tongue is beneath, right? Tongue is before. So it's not shown here, but tongue, just remember, tongue is before. Tongue and the epiglottis are linked together. They are linked together by a fold in the center. And this fold which is linking the tongue and the epiglottis, this fold is called as median glossoepiglottic fold. Median glossoepiglottic fold is a fold which connects the epiglottis to the tongue or the base of tongue. Now, one important question that was asked some time back was, what is the space between the epiglottis and the tongue called as? So do you see this space and this space between the epiglottis and the tongue? This little space over here, these are called as vallecula. These are called as vallecula, which are spaces between the tongue as well as the epiglottis. Okay? Now, what else can you see? Once I go inside the epiglottis, or once I cross the epiglottis, then I'm going to see the laryngeal inlet, right? And I'm going to see certain structures of the larynx, right? Okay? Now, what all can I see? In the center, I would be seeing these vocal cords. Right? These white shining structures in the center, these are called as vocal cords. Or we simply also call them as vocal folds. We also call them as vocal folds. So don't understand, like, don't get confused between whether it is vocal fold or vocal cord. Vocal fold, vocal cord is the same thing. Okay, we call them as folds nowadays. Why? Because folds exactly mean membranes, right? They are membranous folds. And that is the reason why we call them vocal folds nowadays. Okay. अब इसके side में क्या है? What do we see on the side of these vocal folds? We see some pinkish structure over here. These are called as vestibular folds. These are called as vestibular folds. We also call them as false vocal cord. We also call them false vocal cords. So these little tiny pink structures are called as false vocal cords. These white structures in the center like a rubber band, these are called as true vocal cords. Okay, fine. Now, there is a space. Very important question. There is a space present between the true vocal cord and the false vocal cord. Can you see the slit-like space? right? This space little here, can you see this line over here? This space present between the false vocal cord and the true vocal cord is given a name, and that is called as laryngeal ventricle. It's called as ventricle. Okay, so what is a ventricle? Ventricle is a space present between the vestibular fold above and the vocal fold below. So these vocal folds are a little below, and that space, or a tiny little space, is called as laryngeal ventricle. One disease which happens in abnormal dilation of laryngeal ventricle is laryngocele. Laryngocele happens when air gets trapped inside this laryngeal ventricle, and it causes this abnormal enlargement. And that is what is called as a laryngocele. Okay, remember that. Now, what are these cartilages over here? Can you see these cartilages, right? Big round cartilages. These are paired cartilages, right? And what are these? These are arytenoid cartilages, right? You've got two. So these are arytenoid cartilages. These are arytenoids, or these are arytenoid cartilages. Okay, fine, right? So these are arytenoid cartilages, and the space present between the two arytenoids here, this is our interarytenoid space. These are our interarytenoid space. Okay, which is basically present between the two arytenoid cartilages, right? Okay, now the space present between two vocal cords, the space present between these two vocal cords, this is called as rheumatoglottitis. Rheumatoglottitis. Okay, a space present between two vocal cords is called as rheumatoglottitis. And if we go inside the rheumatoglottitis, you can see an area which is present below the true vocal cords. Below the vocal cords, what area of larynx is present? Right? If this is the glottis, the area between the vocal cords is called as glottis. So what is the area present below the glottis? It is subglottis. So what are you seeing here? That's the subglottis, right? So trachea is a continuation of subglottis. So what you are seeing here, this is subglottis, this is subglottis, and subglottis continues down as trachea. Okay, fine, right? Very right. So all of you are answering right. I'm so happy that you guys are with me. Okay, so keep coming up with these answers so that I can understand that you guys are understanding whatever I'm telling you, right? Now, very important folds which have been asked as questions. There is a fold which connects the epiglottis to the arytenoid. Can you see this fold? These folds are called as ary-epiglottic fold, ary-epiglottic fold. And there are two in number which are connecting these arytenoid cartilages with the epiglottis, right? And what do you see here? This is a fold which is connecting the epiglottis to the lateral pharyngeal wall. Can you see this fold? Right? So this fold which connects the epiglottis to the lateral pharyngeal wall, this is called as pharyngo-epiglottic fold. Pharyngo-epiglottic fold. Okay? Simple, right? So there are two folds, ary-epiglottic fold, pharyngo-epiglottic fold. Chalo. Now, two recesses. Recess means the space which are present lateral to the larynx. You can see this is the larynx. Lateral to the larynx, you've got these two recesses on both the sides. These two recesses which are present lateral to the larynx are called as pyriform fossa. They are called as pyriform fossa. One on this side, on the other on this side. Okay, and pyriform fossa continues down into the esophagus. So these two pyriform fossa are going to go down and open inside into the esophagus. Okay, so are we clear? These are the major structures which they can ask you to label as well as find out what is the, what exactly is this area. They might label it and they can ask you as a question. Okay, yes, it is a blind pouch, right? It's coming down. It's an inverted pouch, I can say, and it comes down into the esophagus. Okay, chalo. Now, with this knowledge, now let me start giving you certain questions. Okay, now this is the first image in cases of larynx pathologies. We are going to see all pathologies of larynx here in all images. Okay, now see this image. This is vocal cord abduction. Whenever I'm breathing, there is abduction. When I speak, there is adduction. So the vocal cords close. Now, what do you see in this patient? You will be given a question where a patient will have a history that the patient is a teacher. Let's say I am a teacher. Okay, this is my history, that the patient has got a history of teaching since a very long time, and that particular patient has got hoarseness of voice which has worsened over the past 1 month. Now, this particular pathology very rightly said by Shri Raj and Gautam that this is vocal nodule. Always notice vocal nodules are always bilateral and they occur at the junction of the anterior and mid 1/3 of the cord. Okay, so what I told you, these are your true vocal cords, and at the junction of the anterior, this is anterior, and this is mid 1/3 of the cord, you see there are two tiny white colored nodules, right? So whenever you see bilateral, always remember bilateral small whitish lesions less than 3 millimeters occurring at the junction of anterior and mid third of the cord. And why do they occur at anterior and mid third of the cord? Because during phonation, maximum friction happens at this area. That is why this zone is also called as the striking zone. It's also called as striking zone. Now, this particular nodule, right? Whenever I say nodule, this is something which happens in voice abusers. So voice abusers are what? They are teachers, they are singers, politicians, mothers. All of these people will have a history of vocal nodule. So you can get in your question the same thing, right? Now, very importantly, when this vocal cord will close, it is not going to approximate together properly. You can see it's not approximating properly. So what is it making? It is making an hourglass shape. Hourglass shape. And this hourglass shape is the one which is classically seen in vocal nodules when the person has got adduction. When the vocal cords close, it will create this hourglass shape, okay, during adduction. That is a very important point, okay? Now, always remember, constant voice use. If you are given a history of voice abuse for, years or months, vocal nodule will be the answer. If they ask you a question on sudden abuse, then vocal polyp will be the answer. I'm going to show you how the vocal polyp will come. Because vocal polyp is an acute onset disease. This is chronic. Okay, now the next question will be, what they ask you is, how will you manage this particular patient? Always remember, vocal nodules surgery is not the first line of management. The first line of management in vocal nodules is absolute voice rest. The management of vocal nodule is absolute voice rest. Together with that, we'll tell the patient to take certain drugs with it, right? Certain drugs are given with it. And what are the drugs, supporting drugs? We give a short course of antihistamines. We give mucolytics, okay? And also we give proton pump inhibitors for correcting GERD. Because all of these things, allergy, as well as, GERD, they are all predisposing factors to causing vocal nodule. And that is why we give these kind of supportive treatment with absolute voice rest. Surgery is not indicated as the first line of treatment. Why? Because if we do surgery, there will be more scarring and the voice will become worse. Okay, fine. Now, let's take the second scenario. Now, in the second scenario, this particular person came with sudden voice use, right? He was screaming. Let's say a person had gone to see a match and they tell you suddenly he screamed for Virat Kohli and suddenly he had hoarseness of voice. Now, when that particular patient had got hoarseness of voice, he ran to the OPD to show. We did a laryngoscopy. What did we see? What is the diagnosis? Here. Now, here you see this is not a bilateral lesion. Sudden voice abuse, screamer. What will be the answer? There is only one pathology on one cord. Can you see this? And this will be usually reddish in color. White are nodules, bilateral. Polyps are single and unilateral. So you see here, this is also a vocal cord benign pathology which occurs at the anterior and mid 1/3 of the cord because this is the striking zone for the maximum phonotrauma to happen. Tabhi iska answer will become vocal polyp. One important thing you should remember, sudden history, voice abuse and reddish lesion at the anterior and mid 1/3 of the cord on unilateral side. That is a vocal polyp. Okay, now if medical line of management was something that we were giving in vocal nodule, what is the line of treatment for vocal polyp? It is always surgical. And what do? We do microlaryngoscopy plus excision. We excise this region by doing a microlaryngoscopy, right? And we can excise it, we can cut it out. Yeah. So there is a question by 𝐒𝐿𝐷 doctor, is it always unilateral? No, it can be bilateral. Okay, it can be bilateral in 15% of the cases, but most importantly, it is unilateral. So what you will be given as a case scenario, you will be given a unilateral polyp. Okay, it can be bilateral, that is something can be seen, but always remember 90% of the cases are unilateral. Okay, fine, chalo. Now let's come to the third one. Okay, now this is a history where a 60-year-old man has presented to you. And this particular person has got a history of smoking. Very important history of smoking. since around about 30 years. Now this person has got difficulty in breathing, as well as this person has got hoarseness of voice. Okay, what do you see over here? Right now, this particular pathology is given the name as Reinke's edema. This is called as Reinke's edema. Very important pathology, which is called as Reinke's edema. What is the other name for Reinke's edema? The other name for Reinke's edema is also called as chordal polyposis. It's also called as chordal polyposis. It is also called as pseudomyxomatous laryngitis. Okay, it's also called as pseudomyxomatous laryngitis. It's also given the name as smoker's larynx. It's also called as smoker's larynx. So any of these terms can actually turn up, but Reinke's edema is actually everything means the same, that there is edema in the Reinke's layer. Okay. Now, vocal cord has got different layers. If I take this layer of, if I cut a piece of vocal cord and I show it to you here, vocal cord has got different layers. Okay. What are the layers of the vocal cord? The innermost layer of the vocal cord is made up of a muscle which is called as vocalis. And vocalis is actually the thyroarytenoid muscle internal part. Right? Thyroarytenoid has got many external part and internal part. The internal part is present within the vocal cord, which is called as vocalis. Above the vocalis is a layer which is called as deep lamina propria. Above that, there is another layer which is called as intermediate lamina propria. Above that there is another layer which is called as superficial lamina propria. And above that, there is another layer which is called as epithelium. What are the layers of vocal cord? Epithelium, superficial lamina propria, intermediate lamina propria, deep lamina propria, vocalis muscle. The deep lamina propria and the intermediate lamina propria together are called as vocal ligament. They are called as vocal ligament. Okay, fine. Now just imagine there are a lot of vessels. There are a lot of vessels which are present in this superficial lamina propria. There are a lot of vessels in the superficial lamina propria. Because of chronic smoking, these vessels become fragile. They become fragile. And they start leaking fluid. And this fluid is called as a transudate, right? Whenever capillary permeability increases, it's called as a transudate. And this transudate or fluid gets collected in this superficial lamina propria. It gets collected in this superficial lamina propria. So the other name for this superficial lamina propria is also Reinke's space. We also call it Reinke's space. Okay, so there was a scientist, his name was Frederick Berthold Reinke, who actually got this space first. He discovered this space. And that is why we call that as Reinke's space. Okay, it's subepithelial, just below the epithelium. And that is why there will be edema over there. And that is called as Reinke's edema. Okay, now you will get two questions in this particular chapter. First question will be that in Reinke's edema, whenever you get a female history who has a male-like voice, right? Correct. So now what will happen here? That a female is there, she will talk over the phone, and that female will sound like a man. Why is that? It's because the vocal cord have become bulky. They have increased, they have become bulky. And that is what is, this change in voice will be a classical indication that Reinke's edema is present. Or you will get a history of a man who has been chronically smoking and you see this kind of an appearance. These two histories will be there. Reinke's edema is also related with allergies and hypothyroidism. It is also related with allergy and hypothyroidism. Remember that. Now, what is this appearance of Reinke's edema called as? This appearance where you see, like a polythene bag hanging down. So this is called as bag of water appearance. Bag of water appearance, which is a classical thing seen in Reinke's edema. Okay, now, how do you treat Reinke's edema? Reinke's edema, the first line of treatment is again, stop smoking and absolute voice rest. So you have to tell, stop smoking, absolute voice rest, and the same drugs, what we used to give for vocal nodule, same line of treatment will follow. But with that, if the edema is too much and this bag of water is already formed, we need to do a surgery as well. And the surgery that we do in cases of Reinke's edema is called as reduction glottoplasty. Reduction glottoplasty. This is the surgery. What do? We put an incision over the vocal cord and we suck out all this collection which is formed inside this Reinke's space or the superficial lamina propria. Okay, that's called as reducing the vocal cord so that we can maintain a free edge of the vocal cord, and that is called as reduction glottoplasty. Okay, are we clear till now, right? So we are doing these laryngeal pathologies one by one. So I hope you guys are clear till now, right? Okay, now let's go on to the next diagnosis. What is this? Now here, they will give you a history that the patient is a 14-year-old girl, let's say a girl of 14 years, and that particular patient had history of repeated intubations, right? Repeatedly, that girl was intubated again and again, right? Endotracheal intubations were done. Now the patient has presented to you in the clinic with biphasic stridor. Now what do you understand by biphasic stridor? Biphasic ka matlab, on inspiration and expiration, both you will have a sound. What is this? This is biphasic. And whenever I say biphasic stridor is an emergency and it is a characteristic of subglottic pathologies. It is a characteristic of subglottic pathologies. So obviously I told you, all of you are right, that this is subglottic, right? And what do you see? You see a tiny hole, right? You see a tiny hole below the vocal cord. See, these are the vocal cords, and the subglottic area, which I told you is the area below the vocal cords, is gotten significantly narrowed. And why is that narrowed? Because of repeated intubations. So what will intubation do? Whenever there is intubation, which is happening again and again, the endotracheal tube will keep rubbing over in the subglottic area. And also the pressure which is provided by the cuff, right? There is a balloon in the endotracheal tube. That pressure of the cuff will also cause significant destruction of the mucosal tissues in the subglottic area. And that will lead to this narrowing, or that will lead to formation of a web, and that will narrow. And that is why we call this pathology as subglottic stenosis. So very rightly said by all of you, and Adi has already told that there is a classification system what we do for subglottic stenosis, and that is called as Cotton-Meyer classification. What is Cotton-Meyer classification? Cotton-Meyer has got 4 grades of classification. Grade 1 means that the obstruction is 0 to 50%. Grade 2 means that the obstruction is around 51 to 70%. Grade 3 means that this obstruction is from 71 to 99%. And grade 4 means complete obstruction. The worst obviously is grade 3 and grade 4 where we require surgery. But if the patient is coming in grade 1 and grade 2, we usually do something called as balloon dilation. We do something called as balloon dilation. And we also do laser excision of the stenotic segment. So we give an incision, we'll give an incision, and we'll open this stenotic segment by giving an incision. And with that, we'll put a balloon and we'll dilate this segment. Now, this balloon dilation is serial. We keep doing it weekly, and it has to be done for approximately 7 to 8 cycles till this whole area is opened up. But that is usually done in stage 1 and stage 2. Okay. One more question that they will ask you, that once we have done the excision, right, these edges still are very raw. So what will happen? They will heal back again, and that stenosis will happen again. So how will you prevent re-stenosis? Is there any drug which can prevent re-stenosis after you have done excision? So there is a drug, and that drug is application of mitomycin C. Application of mitomycin C. And mitomycin C is an anti-fibroblastic agent. So it will not let these fibroblasts come again and close it. Right, Gautam? You have already told it's mitomycin C. Okay? So that is something that we do in stage 1 and stage 2. But what about grade 3 and 4? Grade 3 and 4 means that the stenotic segment is very narrow. Here the excision won't work and balloon dilation won't work. So here we need to remove that area, and you understand this area is what? Subglottis area is within the cricoid cartilage, right? Cricoid cartilage is there. It's within the cricoid cartilage, is called as subglottic area. So we need to remove that area, right? So what do? We do something called as cricotracheal resection. Cricotracheal resection with anastomosis. So we will resect out the area of the stenotic segment of the upper trachea as well as the cricoid, and we'll anastomose the remaining trachea back to the thyroid cartilage. That is what is called as cricotracheal resection with anastomosis. That is usually done in grade 3 and grade 4. We also call it laryngotracheal reconstruction. Okay, fine. So this is what you need to understand. Remember, biphasic stridor is the key. Whenever you hear biphasic stridor, think of subglottic pathologies. Okay, that will be the key where they will ask you this particular question. Right? Chalo. Now, what is this particular diagnosis, right? Now, this is the history of a 6-month-old child which is presenting itself with inspiratory stridor And that inspiratory stridor increases on lying down supine or on feeding. So there is a child, 6-month-old, as soon as the child is in supine position, or if the child is feeding, the child develops certain kind of a respiratory distress, becomes cyanosed, and has got some inspiratory stridor. What is the diagnosis? So right, all of you, correct, this is laryngomalacia. That's laryngomalacia. Okay, now what do you understand by laryngomalacia? In laryngomalacia, there are important things that you find, right? So what exactly will you find? In laryngomalacia, you will find flaccidity of cartilages. So the cartilage will become very flaccid. Flaccidity of cartilages. Now if you see here, if the flaccidity of the cartilage, flaccidity means they are all floppy. So if they will increase in flaccidity, as soon as the air current will flow through them, they will become curled, right? They will become curled. So what will happen? As soon as the air will strike the epiglottis, it will become curled. And a very important question, what is this appearance called as? We call this as omega-shaped epiglottis. Omega-shaped epiglottis. Okay. What is the next feature of laryngomalacia? The next feature of laryngomalacia is that with the omega-shaped epiglottis, the aryepiglottic folds, what are connecting the arytenoid cartilages as well as the epiglottis, they become shortened. They become shortened. So there is shortened aryepiglottic folds. That is the second thing, right? What do you see over here? Okay, fine. Now, what do you see next? There, third thing that happens is you have got extra mucosa over these cartilages. Okay, now simply think of that if I'm wearing a double XL t-shirt over me and I go into a windy environment, what will happen? Suddenly that extra shirt will start, right? So what is that going to do? It is not going to fit me, right? It's going to flapper. Similarly, there is extra mucosa that forms over these cartilages over in laryngomalacia, and we call this extra mucosa as redundant mucosa. Redundant mucosa. So what are the three things that you see in laryngomalacia? You see flaccidity of cartilages, you see shortened aryepiglottic folds, and you see redundant mucosa. And these are the reasons why whenever the patient will breathe, they will develop sudden curling of the epiglottis, and there is a very narrowed laryngeal inlet. That is why these children, whenever they lie down supine, because on supine, your epiglottis falls back, they will have inspiratory stridor. Right? Okay. Now, the question will be, how will you approach this particular case? Remember, in the earlier stages of laryngomalacia, we do not do any surgery. There is no medical line of management. So we do not do any surgery in the earlier stages. We only tell the patient to have proning. We always tell the mother to have proned nursing. That means don't let the child be in supine position. Keep it in prone position so that the epiglottis can fall forward. So we wait and watch. If the child is coming in cyanosis, if the child is having respiratory distress, and if the child is having drop in oxygen saturation, then only we require to do a surgery. Otherwise, we usually do proned nursing. Okay, and we never tell the mother to feed the child in supine position. Always keep the head end a little elevated whenever the person is feeding the child. Okay, so wait and watch is the first line of management, because these cartilages will gain strength as the time passes. Okay, so after 1-2 years, these symptoms will become better. But if the child has got decreased in saturation, then we do a surgery. And what is the surgery that is done for laryngomalacia? The surgery that we do for laryngomalacia is called as supraglottoplasty and epiglottopexy. Epiglottopexy. Okay, so these are the things that we do, right? Supraglottoplasty and epiglottopexy. Now, what do you mean by that? Basically, what do we do in this? We cut this aryepiglottic fold so that we can release the epiglottis and it can uncurl itself, right? And so that the epiglottis does not fall back, right, over the laryngeal inlet, we actually take a suspension suture from the epiglottis to the base of tongue. So we take a suture, that's called as a suspension suture, from this epiglottis to the base of tongue so that the epiglottis does not fall, it remains straight. And at the same time, we cut open these aryepiglottic folds so that uncurling of the epiglottis happens. We call that as supraglottoplasty as well as epiglottopexy. Okay, fine. So this is all about what you need to know as far as laryngomalacia is concerned. Chalo. Now let's come to the next one. What is this? What do you see here? Now here the history is that this particular patient had got a viral infection some 7 days back. Okay. And after the viral infection, the patient developed hoarseness of voice. The patient did not care about it and he continued to have some kind of local treatment. And after 15 days, the patient came to the OPD to show his symptoms. You did a laryngoscopy and you found this kind of an image. What is the diagnosis of this particular patient? This is what they are going to ask you. Now, what do you see in this case? I told you there is a history of viral infection, right? Okay. So, what exactly is this, diagnosis? Now, always remember, if they are asking you these kind of histories, right? If they are giving you these kind of histories, there is a clue behind them. That means there is a viral infection which has caused some kind of problems inside the vocal cords because they are showing the vocal cords. Okay, fine. Okay, thank you, Rashmi. Thank you. I hope you guys are enjoying whatever ENT is going on. Right. So what do you see over here? You see two vocal cords. One is this and one is this. Okay, that is what you are seeing. Now, if you see vocal cords go away from each other, when we call as abduction, and they come together, that is called as adduction. Okay, fine. Now, what has happened to one of the cords? One of the cords is actually not going away. If you see very closely, one cord has not gone away and the other cord has gone a little away. Right? One cord is still gone, it's still at the same position. So one cord is still at the same position, but one cord is moving. Right? One cord is moving, one cord is not moving. And what is that called as? That's called as unilateral recurrent laryngeal nerve palsy. Unilateral recurrent laryngeal nerve palsy. Thank you for a lot of love that you guys are showing me. Thank you. Okay. Now think of this particular thing. What is recurrent laryngeal nerve? Recurrent laryngeal nerve supplies all the intrinsic muscles of the larynx. Always remember that, except there is only one muscle which is not supplied by recurrent laryngeal nerve. That is your question. Very commonly asked question everywhere. So the only muscle which is not supplied by recurrent laryngeal nerve is cricothyroid muscle. And cricothyroid is supplied by superior laryngeal nerve. Right? So cricothyroid is supplied by superior laryngeal nerve, and a cricothyroid is a tensor as well as an adductor of the vocal cord. It's a tensor and adductor of vocal cord. Okay? Now, if the person has got unilateral recurrent laryngeal nerve palsy, let me just draw it to you over here. Okay? Let's say this is your base of tongue. Okay? This is the epiglottis. Okay? This is your aryepiglottic fold and arytenoids. Okay, and this is your median glossoepiglottic fold, which we have already discussed. Okay, you have got two vocal cords over here. These are your vocal cords. Okay, now two questions I'll ask you. Which is the abductor of vocal cord? What muscle is the abductor of vocal cord? There is only one muscle which is an abductor of our vocal cord. Only one muscle which is an abductor of our vocal cord, and the only abductor of our vocal cord is posterior cricoarytenoid muscle. Posterior cricoarytenoid muscle, yes, correct. It's the only abductor of the vocal fold. Always remember that. Very many times it is asked, right? And it is supplied by recurrent laryngeal nerve for obvious reasons. Why? Because recurrent laryngeal nerve is supplying all the intrinsic muscles of the larynx. So RLN is supplying posterior cricoarytenoid, which is causing abduction whenever we are breathing, right? Now, when we cause adduction, adduction is by what? Adduction is when we speak, right? So the other muscles of the larynx are basically causing adduction. Correct? They are also supplied by recurrent laryngeal nerve, except for cricothyroid muscle, which is supplied by superior laryngeal nerve. Now imagine, let's say this particular person had got recurrent laryngeal nerve palsy on, let's say, left side. This is the right side and this is left side. And this side RLN got injured, or it's not working. It's not working. Now this history, they can give you after a viral infection also, because it is usually idiopathic. And that is why viral infections, post-viral infections, RLN, can get inflamed. Okay, so they can give an idiopathic history, most common. But they can also give you a history that, let's say this particular patient went for a thyroid surgery. And just behind the thyroid is recurrent laryngeal nerve. And that got injured. Let's say this injury has happened over recurrent laryngeal nerve. Now what will happen? There is a theory which is given by Wegener and Grossman. And we call that as Wegener and Grossman hypothesis. What does it say? If any person has got unilateral RLN palsy, still their cricothyroid is functional because it is supplied by superior laryngeal nerve. So now what will the cord do? The cord will attain a position, and that is called as paramedian position. Now the cord will attain a position which is called as paramedian position. That means this cord will not move. It is just going to stay in this paramedian position. And the other cord will still move. Now let's say this particular person did abduction. So the other cord went away and this cord went stationary. This cord is in the center. So that is why what you see here is one cord is in the center, the other cord is going away. Why? Because the unilateral recurrent laryngeal nerve is damaged. But still, the superior laryngeal nerve is functional. If the superior laryngeal nerve is functional, the cricothyroid will tense the cord and this paralyzed cord will attain a paramedian position. It will stay in the center like this. Only the other cord will move here, then come up. Move here, then come up. Move here, then come up. So the other cord is compensating for the function of the paralyzed cord. Remember this. In unilateral recurrent laryngeal nerve palsy, which is the only muscle which is functional, it is cricothyroid. What will be the position that the cord will attain in a paralyzed RLN? The cord will attain a paramedian position. Why? Because of the tensing action of the superior laryngeal nerve. Only the other cord will keep working. Now the second scenario comes. If both the recurrent laryngeal and as well as the superior laryngeal are injured. Let's say this particular person had unilateral SLN plus RLN palsy. Both nerves are injured. I told you only RLN, paralyzed cord is in paramedian position. But let's say now both of them are injured. Both SLN and RLN are injured. What will be the position of the cord now? The position of the cord now will be cadaveric position. The position of the cord will be cadaveric position. And what is cadaveric position? Cadaveric position means that the paralyzed cord will be 3.5 millimeters away. It will be 3.5 millimeters away from the midline. This is the midline. So it will be 3.5 millimeters away from the midline and it will stay there. So I told you two things. In unilateral RLN palsy, the cord which is paralyzed is going to attain a paramedian position because of the working SLN, which is going to cause adduction from the cricothyroid muscle. If the cord is paralyzed by both SLN and RLN, then this paralyzed cord will attain an intermediate position or a cadaveric position, which is 3.5 millimeters away from the midline. Remember this important situation. Okay, so always remember these two things. Both these questions have been asked, that what is the position of the cord in unilateral RLN palsy? What is the position of the cord in unilateral SLN plus RLN palsy? And I hope you guys have got it. Okay, if there's any question, you can just pop it over on the comment box. I'll answer it straight away for you. Okay, fine. Chalo. Now let's move on to the other one. Let's move on to the other question because I've got tons of images for you. This is a question which was given off recently in your NEET PG. And this is a question about a patient who underwent intubation. Okay, let's say Adi has asked, cadaveric position is normal. No, cadaveric position is one position which never happens in a vocal cord. It only happens whenever there is complete palsy of unilateral plus RLN palsy. Right? If unilateral RLN and SLN are injured, then only the cord will attain cadaveric position or intermediate position. Never will it attain any position in its life if it is not paralyzed. Also, cadaveric position is also seen in cases of when the patient is in general anesthesia or after death. So these are the three situations only where you see cadaveric position. Okay, so let me get back to this question now. So the patient underwent intubation for a gallbladder surgery, and now this particular patient has got this kind of hoarseness of voice, right? And when we do a laryngoscopy, we see a kind of a lesion at the posterior 1/3 of the cord. Remember that? This is posterior 1/3 of cord. So you see a lesion at posterior 1/3 of the cord, right? And there is a history of intubation. So what happened in this patient? Maybe during intubation, he had got some injury, and that injury created a lot of granulation tissue formation, and that granulation tissue formation formed a granuloma. So the answer, very rightly said by Vaishali and Vidyalakshmi, it is intubation granuloma. Intubation granuloma. Catch point is they will occur at posterior 1/3 of chord. Remember that. They will occur at posterior 1/3 of chord. They will not be phonatory pathologies. They are usually going to be at the posterior 1/3 of the chord, which is also called as respiratory glottis. Remember, the anterior 2/3 of the glottis is called as phonatory glottis, and the posterior 1/3 of the chord is called as respiratory glottis. They will happen over the posterior 1/3 of the chord, because the posterior 1/3 is a cartilaginous part of the chord. And these are the ones which get injured during intubation, because here only the maximum, strike of the intubation tube happens. Okay, fine. So the answer will be intubation granuloma. What is the most common way of treating it? So usually if it is large, we remove it. In the earlier stages, we can even give corticosteroids. So we can try corticosteroid treatment, right? Oral corticosteroids. If it's not, getting healed, if they are very small, they usually heal off. If they are very large, then we have to do a microlaryngoscopy and excision. Microlaryngoscopy and excision. Okay, fine. So this is a question for intubation granuloma. Chalo. Now let's go on quickly to the next one. Okay, now this particular patient is a child who's of 3-year-old, school-going child, and that particular patient ended up in the emergency with drooling of saliva, dysphagia, as well as difficulty in breathing. We did a laryngoscopy and we found a very erythematous, red-colored epiglottis. So we found a very erythematous, so there is erythema, and red epiglottis. So this is also called as cherry red epiglottis. This is also called as cherry red epiglottis, because if you see, it is like a cherry, right? It's a big cherry red, right? And this is classical for acute epiglottitis. This is classical for acute epiglottitis. Correct, all of you. This is acute epiglottitis. Now, what is one question that they ask you? What is the most common organism for acute epiglottitis? 2 organisms you need to remember: Haemophilus influenza as well as Streptococcus pneumoniae. There is even Staph aureus, but 2 most important are Haemophilus influenza type B, as well as Streptococcus pneumoniae. Okay. Now the incidence of Streptococcus pneumoniae has increased. Why? Because Haemophilus influenza type B vaccines have come, which we usually give to school-going children. Okay. Fine. Now, if they have got a huge epiglottis, obviously, when they sleep, the epiglottis falls back, and that will cause a lot of distress. So they will sit like this. And this position in which they are sitting for breathing better, this is called as a tripod position. This is called as tripod position. Okay, very important question. Right. Now, Vidya Lakshmi has already told, which is my next question to you, that if you do an X-ray, which I have discussed in my radiological imaging segment, okay, I have a separate thing for radiological images. Please go through that. It's already on YouTube. So, in that, I have discussed that there is an X-ray sign which is seen in epiglottitis, and that is called as thumb sign. That is called as thumb sign because it actually looks like a thumb when you do an X-ray. Okay, that's called as thumb sign. That is all what you need to remember. Now, how do you treat epiglottitis is a question. So I have a mnemonic for you. Croup versus epiglottitis, both are dealt in the same way. Croup means laryngotracheobronchitis, right? So it's a lower airway disease. Now always remember, when they give you a history of a child of 6 months, 1 year, that is usually less than 2 years of age, the answer would be croup. But if they give you any kind of a history like difficulty in swallowing, breathing, and the child's age is around 3 to 4 years, then the answer will be epiglottitis. Because croup usually happens in the earlier age group, right? Around 6 months, 1 year child, right? Okay, now, also, another important part, croup is a viral infection, epiglottitis is a bacterial infection. Okay, so croup usually happens because of parainfluenza and influenza viruses. Epiglottitis happens because of Streptococcus pneumoniae and Haemophilus influenza type B. Now I'll tell you a mnemonic, not as well as that is a treatment strategy for both croup and epiglottitis, and I call it as my 6H strategy. Whenever patients come with epiglottitis, first you need to hospitalize. That is the first H, hospitalization. Okay. Second H is hydration. Hydration means you give a lot of IV fluids because these babies are not eating well. Okay, so you open a cannula, give hydration, give IV fluids. Okay. Third H is high-grade antibiotics. High-grade antibiotics that usually is given for penicillins. We give cephalosporins, right? Such as ceftriaxone. Okay. What is the fourth H? Fourth H is head end elevation. Head end elevation. Never ever lie down, let them lie down supine. Always make them a little straight so that they can breathe better. Fifth H is hydrocortisone. So we give them steroids for reducing the edema that is present over in the epiglottis and the supraglottic structures. So that is hydrocortisone injection that is given, okay, according to the child's weight. And the sixth H is high dose nebulized racemic epinephrine. Racemic epinephrine. Okay, so this epinephrine is actually a life-saving drug even for croup as well as epiglottitis. What is epinephrine? It's a non-selective alpha and beta agonist. So it's a non-selective alpha and beta agonist. Okay, this epinephrine drug. So alpha receptors are found over our blood vessels. Beta 1 receptors are found over in the heart. And beta 2 receptors are found over in the airway, in the smooth muscles of the airway. So if we give this epinephrine in a nebulized form, if it acts on the alpha 1 receptors, they cause vasoconstriction. So if the vasoconstriction happens, obviously the edema will reduce, right? Because these vessels are going to be vasoconstrict, there will be more space for the child to breathe. Beta 1 is heart, so they will increase the stroke volume in the heart. That will provide better circulation. And beta 2 is airway, so they cause bronchodilation by causing smooth muscle contraction. So when the smooth muscles will contract, they will cause bronchodilation. So all of these three receptors are activated by if you give a nebulized epinephrine, and that is again life-saving for these people. Okay. Can laryngoscopy be done routinely? Laryngoscopy, whenever you have the child who is, we should do it routinely if the child is comfortable for it. Okay. Because we are at least going to see these signs. If the child is not comfortable for your examination, and let's say, the child is very anxious, these children will, have desaturation, they will appear in the emergency, then in those cases we do scans. Okay, then we can see the clinical history, we can have some kind of a diagnosis about them in our mind, and we can straight away go for radiological testing, because they won't allow you to do a laryngoscopy so easily. But if the child is a little grown up, then in those cases you can do a laryngoscopy. But actually it's the best way to do it. Okay, we usually do it with the from the nose, right? So that's called as flexible nasopharyngolaryngoscopy. Okay, fine. So I hope this is answered and you guys have understood about epiglottitis and croup together. Fine, chalo. Now let's come to another important situation. Now this is a question for instruments and this is for tracheostomy tubes. Okay, now two types of tracheostomy tubes are there. One is Portex and the other one is this, that is your metallic tubes. Now what are the questions that they will ask you? They will give you a kind of an image and they will ask you what is the type of metallic tube that is shown here. Okay, now remember, very easy way. If they show you 3 elements in a tube, 3 element diye hue, they are showing 3 elements. What is that? There is an outer cannula, then the inner cannula which goes inside the outer cannula, there is an inner cannula, and then there is something called as obturator. Right? Later on the obturator is removed, but because this obturator has got a bulb, this is kept for atraumatic entry inside when we are putting the tracheostomy tube. So obturator goes inside the inner cannula goes inside the outer cannula. This assembly of 3 things together forms something called as Jackson's metallic tube. It forms something called as Jackson's metallic tracheostomy tube. Okay, fine. This is a Jackson's metallic tube. 3 things, always remember: obturator, inner cannula, outer cannula. All 3 together, they will attach into one assembly. Later on, the obturator can be removed. But this is called as Jackson's metallic tube. If you have only 2 assemblies, one is an outer one and one is an inner one. So this is called as outer cannula. This is called as outer cannula. This is called as inner cannula. Okay. So if you've got an outer cannula, you've got an inner cannula, right? And you see the outer cannula has got 2 valves, right? It has got 2 valves. So we also call it bivalved. What is the answer over here? This is a Fuller's bivalved metallic tracheostomy tube. This is Fuller's bivalved metallic tracheostomy tube. Okay, always remember 3 Jacksons, 2 Fuller's. Fuller's has got these 2 valves for atraumatic entry, so that the tracheostomy tube does not injure. So this valve can close in and out. So that is why this outer cannula is bivalved, right? And the inner cannula of this Fuller's metallic tube also has got a small hole, and this is called as a fenestration. This is called as fenestration. So if you see, this fenestration is absent in cases of Jackson's metallic tracheostomy tube, but is actually present in cases of Fuller's bivalved metallic tracheostomy tubes. That is why Fuller's is more commonly used. Why? Because this fenestration has been given. This fenestration can be utilized for phonation. Okay, whenever there is a hole inside a tracheostomy tube, so this can be utilized for phonation in patients. Okay, fine. Now, these are metallic tracheostomy tubes, right? So they are made up of what? They are made up of German silver, which is an alloy of copper, silver, and phosphorus. So copper, silver, and phosphorus together, they form these alloys, right? And this is usually German silver, which these are made up of. Now, Adi is asking what to do in cases of tracheostomy tube which is partially blocked and what to do when it is completely blocked. So the answer would be, if any tracheostomy tube is partially blocked, what do we do? First, we take a suction tube and we suction out the secretions. What are blocking it? If your suction can go in, it can take out that mucus plug, which is usually the one which blocks it. Also, we add certain saline drops. We can add a drop of saline into it so that the mucus liquefies and then we can suction it out. If by any chance you are hearing a noise from the tracheostomy tube, that means it is partially blocked or it is completely blocked. That means the patient is getting cynosed. Take that tracheostomy tube out, put a new one inside. Okay, we have to change the tracheostomy tube in cases of full obstruction. Okay, Rashmi, you missed. Okay, so Jackson's metallic tube has got 3 assemblies. An obturator, which is the inner, goes inside the inner cannula goes inside the outer cannula. There are 3 assemblies, okay, for the Jackson's metallic tube. If you see 3 things, it's Jackson's. If you see 2 things, outer cannula, inner cannula, and it is bivalved, it is Fuller's. Okay, fine. So I hope you guys have understood about what exactly are these metallic tracheostomy tubes. Okay, now one important question is that they ask you if Fuller's, if let's say there was a kind of a silicone tracheostomy tube that was put. Okay, so Vidya Lakshmi is asking about site of tracheostomy in high and its indications. Okay, let me tell you that after this image. Okay, fine. So in cases of whenever you're putting metallic tubes, right? Initially, metallic tubes are never put. Initially, what do we put? We put a normal Portex. Portex is a silicone tracheostomy tube. I'm going to show you that image. But initially, we put a silicone tracheostomy tube or a Portex tracheostomy tube. Later on, we change it to a metallic tube when the patient is going home. Okay, if we require it for a long time. How to calculate the size? If the patient has got a, let's say, a 7 mm Portex tracheostomy tube, Portex, okay, what do we do? For changing it into a metallic one, multiply it into 4. If it is 8 size, multiply it into 4, that becomes 32 size metallic tube. If it's 7, multiply into 4, that becomes 28 size metallic tube. So usually the Portex tube, when we are changing it into a metallic tube, we multiply the size of the Portex tube into 4, and that is in mm, and that would give us the size for these metallic tubes. Okay, so remember this, right? Chalo. Now let me come to the question that has been asked to me from Vidya Lakshmi, that what are the sites of tracheostomy, and then I'll explain you this tube. What is our Portex tube, right? So this is the Portex tube, right, which is a silicone tube. This is a silicone Portex tube. Now first I'll tell you what are the sites of tracheostomy. Tracheostomy can be done at 3 levels. One is called as a high tracheostomy, one is called as a mid tracheostomy, and one is called as a low tracheostomy. Okay. So let me just draw, let's say this is your cricoid, this is a cricoid, this is a trachea, this is a trachea. Okay, this is the first tracheal ring, second tracheal ring, third tracheal ring, fourth tracheal ring, fifth tracheal ring, and so on. Okay, now what is high, mid, and low? Okay, so always remember the ideal situation to do a tracheostomy whenever we want to choose. We never choose high or low. We always choose the mid domain. And why is that? I'm going to tell you later on. But the ideal one is mid tracheostomy, which is done at the level of 2nd to 4th tracheal rings. If we do a tracheostomy between 2nd to 4th tracheal ring, this is called as mid tracheostomy. If we are doing emergency, if we are doing elective, no matter what, we have to do it in middle. And why not? I'm going to tell you later on. Why not we do it high and low? Now, so in routine cases, mid tracheostomy is the one which is usually utilized. What is that? Between 2nd to 4th tracheal ring. If we do anything above the 2nd tracheal ring, we call that as high tracheostomy. That means the first tracheal ring is usually the one which is involved here, where we put a hole. So now, in what conditions will we do high tracheostomy? High tracheostomy is usually indicated when we are doing laryngectomy. When we are doing laryngectomy. So laryngectomy means what? Removal of the larynx, right? So why do we do high tracheostomy there? Because if we do a tracheostomy over here, in high cases, anyways, the cricoid, thyroid and everything is going to be removed. So we are going to save as much trachea as possible so that we can suture the trachea over to the skin here. We need more trachea. We want to save as much normal trachea as possible. And that is the reason high tracheostomy is indicated only in cases of laryngeal carcinomas which are planned for laryngectomies. Okay, fine. Now, what is the problem if you routinely do a high tracheostomy? If let's say there is no laryngeal carcinoma, but you routinely did a kind of a tracheostomy at this level. What is the most common problem with high tracheostomy? If you put the tube at this site, it is going to keep rubbing your cricoid cartilage. And if it keeps rubbing the cricoid cartilage, one common problem will be chondritis of cricoid. And chondritis means inflammation of the cricoid cartilage. If the cricoid cartilage will get inflamed, it's horribly painful. And that is why we avoid doing a high tracheostomy in the regular domain, in the regular cases. Okay, we choose mid. And that is something which is obviously very easy for us. Okay. Now let's say low tracheostomy. When do we do low tracheostomy? Low tracheostomy is usually indicated if the upper segment is got stenosis. Let's say there is stenosis in the upper segments. Or let's say there is some kind of a trauma. Okay, let's say a patient underwent a laryngotracheal trauma. Okay, or if there is any wound above, let's say there is an ulcer or a burn which is above. So in any kind of wounds, ulcers, in those cases we'll do a lower tracheostomy so that we can get some sight. But the only problem is the lower tracheostomy we do, they are very near our apex of the lungs. So the pleura is very near this lower trachea. When we are doing a low tracheostomy, the pleura is very near. So accidentally you can actually puncture the pleura and that can lead to pneumothorax. So the most common problem with low tracheostomy is iatrogenic pneumothorax. High, the problem is chondritis, and that is why we do a mid tracheostomy. Okay, I hope you guys have gotten your answers as to what level tracheostomy we can do. At the same time, if we can do tracheostomies in two ways, one is an emergency tracheostomy, one is a elective tracheostomy. Elective tracheostomy, we usually give a horizontal incision in the skin crease, 2 finger breadth above the suprasternal notch. So you extend the neck, just 2 finger breadth above the suprasternal notch. Here we give an incision in a horizontal plane. That's elective. And why do we do horizontal? Because it looks neat. Because if the wound will heal, right? So it will have that skin crease, that healing will be nice. It won't be a very bad scar. But in cases of an emergency, we usually do vertical tracheostomy, where we put an incision from the lower border of the cricoid down to the suprasternal notch, and we open it. So vertical is a little easier. Why? Because the retraction of tissues is in the same line. But also, post-operative keloids, post-operative hypertrophic scars are more common in cases of vertical tracheostomies in comparison to horizontal tracheostomies. Okay, so there are two ways of giving incisions, horizontal and vertical. Vertical is given in emergency. Horizontal is usually given in cases of elective. Okay, fine. Chalo. Now let's come to this. This is a Portex silicone metallic tube. A silicone tracheostomy tube. Okay. Now, what does this have? So this usually has got two forms. One comes as cuffed tube and one is uncuffed tube. What do you mean by cuffed and uncuffed? If they have a balloon, we call them as cuffed. If they don't have a balloon, we call them as uncuffed. Okay, fine. Now, what are the parts of this tube? You have got a connector, which is called as a 15 mm connector. And this is the one which we attach the oxygen to. Okay, so this is our 15 mm connector at one end. This is called as a phalange, right? This is called as a phalange. This is called as a shaft of the tube, shaft of tube. This is called as the balloon. This is called as balloon, right? And this balloon, if you see, is actually attached by this blue line into this kind of a cuff, right? So this balloon is attached to this blue line, and this line is called as insufflation line, which is attached to this cuff, and this is called as pilot cuff. This is called as pilot cuff. And it has got a red colored valve. It's got a red colored valve. Okay, now what exactly is the meaning of these things? When we put the tracheostomy tube inside, right? Whenever we were putting the tracheostomy tube inside, if we want to open this balloon, or if we want to open, open the cuff, right? Or we want to inflate the balloon, what do? We take a 5 or 6 ml syringe and we attach to this one-way valve which is present over here, the red valve. And we push up 6 to 7 ml of air through this valve. And what will it do? It will send that air through this insufflation line and it will inflate our balloon. It will become inflated. Now, the best part about cuffed tracheostomy tubes is, cuffed means they have a balloon, is whenever the person is going to aspirate, right? Let's say the person has got stroke. So they are not even, even the saliva is trickling down into the larynx. They are not able to control any secretions over here. So stroke, comatose patients, right? Those patients who have got chest weakness, those patients who have got pneumonia, those patients who have got brain injury, in those patients, you cannot control the pharyngeal muscles, right? So that they can swallow their secretions. So what happens is, this cuffed tracheostomy tube is indicated in those patients which are aspirating, right? So when you inflate the cuff, the balloon will become inflated, and when the balloon will become inflated, all the secretions will go and they will lie above the balloon. So the patient will prevent from aspiration. That is the most important point for using cuffed balloons. If the patient is not aspirating, if you're using tracheostomy tube only for relieving the upper airway obstruction, then you don't require cuffed tubes, you only require uncuffed tubes. Okay, fine. So these are the set things that you should know, at least about some things about what is a Portex tube, what are the levels of tracheostomy, and what is metallic tube. Right? Chalo. Now we have completed about some things what are tracheostomy tubes, and this is enough for your questions to be answered in your papers. Chalo. Now let's come to some kind of questions on vocal rehabilitation, which have been closely asked in your exams. That, let's say a patient underwent a laryngectomy or total removal of the larynx, and there is a hole here through which the patient is breathing. Okay, let me show you that. Okay, let's say this is the hole of the patient through which the patient is breathing now, right? Now, what will be this particular technique of rehabilitating this patient? So this machine over here, which is handheld, and it is put over the submandibular fossa. At the submandibular fossa, you can see here, the patient is holding this machine. This machine is very rightly said by you all. This is called as electrolarynx, which is a way in which we rehabilitate patients with laryngectomy. So what is this electrolarynx? You can see this button over here. So this button, when the patient will press, and because obviously there is no larynx, the patient cannot talk. There's no larynx over here. The trachea is directly sutured onto the skin. There is a permanent hole now. The patient is aphonic. He cannot speak because there is no vocal cords, no larynx. But still the patient can speak by certain methods. So handheld electrolarynx, let's say this is my electrolarynx. So what will I do? I'll just push this along my submandibular fossa and I'll press this button. Now this button will create a sound, type of sound, a robotic sound. And that sound will actually go inside in the form of vibrations inside the oral cavity. It will go inside the oral cavity. And now what will I do? With this robotic sound, I'm going to articulate that sound in the form of speech. And I'm going to speak to you. So it is a very robotic speech which the patient has over this. The moment they will, press that, the sound will get generated and the patient can, articulate those words and speak. And this is one way of rehabilitating laryngectomy patients, and it's called as electrolarynx. Okay, fine. So this is a very important question. Please see this, how it looks like. And this is the button where the patient will adjust, okay, the sound what is coming inside the oral cavity. Okay, now another way of rehabilitating a patient with laryngectomy is the second question. What is this? Now, this is a recently asked question. So what is this? And the name of this particular, there's a particular name of this particular instrument also, right? So this is called as a tracheoesophageal prosthesis. Tracheoesophageal prosthesis. Okay? Right? This is a tracheoesophageal prosthesis. In simple words, they can also give a short form as TEP, T-E-P. Okay, so this is a tracheoesophageal prosthesis. Now, there is a name for this tracheoesophageal prosthesis which they will expect, and Vidya Lakshmi has already answered, even Adi has answered. There is a name for this tracheoesophageal prosthesis, and this is called as Blom-Singer prosthesis. Okay. Now, what is the idea of this tracheoesophageal prosthesis? Okay. Tracheoesophageal prosthesis has got two important valves. It has got two important valves. One is called as a larger valve and one is a smaller valve. That means one is out and one is in. Larger valve is called as the esophageal valve. This goes inside into the esophagus. And the smaller one is called as the tracheal valve. And this is called as a stick. Okay, so these are silicone processes. They are also made up of silicone. Okay, silicone is one material which is used in a lot of ENT surgeries, and it's one material which does not produce, also. Okay, so what will this tracheoesophageal processes do? How will the patient speak? Now see this particular patient, right? Now you can see that this tracheoesophageal processes is already put or pushed inside into the tracheoesophageal space. Now how do we do that? Now, this is the hole of the tracheostomy of the laryngectomy patient through which the person is breathing, right? This is the hole, permanent hole, right? This is the trachea. This is the trachea, right? And behind the trachea, this is your esophagus, right? This is the esophagus behind the trachea. So what do we do? Through this hole, this is the posterior wall of the trachea. This is the anterior wall of trachea. In the posterior wall of the trachea, you know that posterior wall of the trachea has got a muscle which is called as trachealis muscle. It is not cartilaginous. So that is what we are going to use. We are going to put an incision in the posterior wall of the trachea and we are going to open it. Now once we put an incision in the posterior wall of trachea and open it, then what is behind it? The anterior wall of esophagus. Just behind the posterior wall of trachea is anterior wall of esophagus. So what we are going to do? We're going to give an incision through and through between the trachea and esophagus, posterior wall and anterior wall, and we are going to push this processes through it. We're going to push it inside. Okay, so I told you there are two valves. One is the tracheal end, one is the esophageal end. Esophageal end is the one which is bigger, it will go inside. Tracheal end will lie down anteriorly. And that is how we have pushed it inside. Right? Now the magic begins. Now what exactly is the principle of it? Now if the patient wants to talk, how will the patient talk? Now if the patient is wanting to speak, he will close the inlet of the laryngectomy opening. He will close that inlet. And when he closes that inlet, the expired air which is coming out from the lungs will now not come out. It will get redirected into this processes. It will get redirected inside. And once it gets redirected inside, it will come into the esophagus. And what will it do? It will vibrate the esophageal column. It will cause vibration. And vibration of the esophageal column will create a sound. And that sound will come through the mouth and the patient will be able to speak. So this requires. Okay, so I hope you guys are hearing me now. Right? Is it still stuck? There was some kind of an internet issue. So I hope you guys are listening to me. You can just tell me if you guys are listening. Okay, is it sorted? Okay, fine, good, great. Fine, so let's come back to where we were. Chalo. Now, this is a particular story of about a 5-year-old boy who has come to the ENT OPD with symptoms of hoarseness of voice, a weak cry, and at the same time, the patient is also having certain type of, disturbance in respiration. Right? Okay? Right? So now we have got a weak cry, you have got hoarseness of voice, and you have got respiratory obstruction. And now you see a laryngoscopy of this particular patient. And when you have a laryngoscopy of this particular patient, you see these kind of multiple lesions which are present on bilateral cords. Okay, you have got these multiple lesions that are present over these bilateral cords. Right? Now, what is this particular diagnosis of this case? Now, you guys have to tell me. Okay, you want a summary on the Bloom-Singer processes? I'll come back. Okay, I'll come back in the end and I'll give it to you. Right? I'll come back in the end. Right? Okay. No issues, no issues. I'll come back in the end and I'll teach you Bloom-Singer again. Okay, fine. So I'll teach you Bloom-Singer again, right from the beginning. Right? So what is this now? What is this particular lesion? And what is this particular pathology? Very important. Now, this is a pathology which is called as recurrent respiratory papillomatosis. This is called as recurrent respiratory papillomatosis. Okay, where you see these kind of multiple papillomas which are formed in the vocal cords. Okay, now this particular disease is related with HPV infection. Is related with HPV infection. Now always remember there are two strains of HPV. One is called as a low risk strain and one is called as high risk strain. Low risk strain are 6 and 11. High risk strains are 16 and 18. So the high risk strains 16 and 18 are more linked to head and neck malignancies. The low risk strains 6 and 11 are usually related with genital warts. Okay, even papillomas are related with low risk strains. They are not malignant, they are benign lesions, but they are related with low risk strains or 6 and 11 strain of HPV. Okay, fine. Now, there are two types of papillomas. One which happen in the earlier part of the childhood, right? One which happen in the late adulthood. So if they are having these papillomas which are earlier in the onset as far as age is concerned, we call them as juvenile onset recurrent respiratory papillomatosis, which happen usually in children. But if they are happening in adults, we call them as adult respiratory papillomas. What is the difference? Whenever you see multiple types of papillomas, they are always juvenile. Children will have multiple papillomas. Adult papillomas are usually single. So usually if you see a single lesion, then it is adult. If you see multiple lesions, you will have juvenile onset, or it is a child which is, having it. Okay. Also, recurrence is more common in cases of juvenile. If you take them out also, recurrence will be more than in cases of adults. Adults will have lesser recurrence. The children will have more recurrence. Okay. Why? Because they are multiple. Okay. Now, one more important thing. If I ask you which has a higher chances of becoming a malignancy later on, adult have less recurrence, but they have a chance of becoming into a malignancy more. So adults are having a higher chances of turning into malignancy. Children have got a lower chance of developing malignancy. These are the differences between adult as well as juvenile onset respiratory papillomatosis. Happens because of HPV. Low risk strains which are 6 and 11. Okay, fine. Now, how do we treat them? So treatment usually has got antiviral drugs. We have got certain antiviral drugs, which was recently asked what is the drug of choice. So the drug of choice for this is cidofovir. And recently we have got something called as bevacizumab, which is a monoclonal antibody. So bevacizumab is a monoclonal antibody which has recently been used a lot in cases of respiratory papillomatosis, as well as we have got an antiviral drug which is cidofovir. These are the drug of choices which we can give in cases of respiratory papillomas. But if they are huge, if they are a lot, then we have to undergo an excision by microlaryngoscopy under general anesthesia. So if they are a lot, then we have to excise them. Right? Okay. So this is about what we do in cases of respiratory papillomatosis. Okay. Now, one trick question let me ask you. Let's say a patient has come to you with respiratory papillomatosis and there's a child, right? And this child is having upper airway obstruction, like the child is not able to breathe. What is the first thing that you will try to do in this patient? Is it an intubation or is it a tracheostomy? Think and answer me this question. Child has got respiratory obstruction. What are you going to try do this in this patient? Is it going to be an intubation attempt or is it going to be a tracheostomy? Okay, what are you going to do in this patient to save the airway first? Because airway is our God. We first need to let the child breathe. And then only we can go ahead and, give all these drugs and all these things in this patient. Okay, Vidya Lakshmi thinks that it is a tracheostomy. Right? Is there anyone who wants to try it out? Anyone else who wants to try it out? Adi also thinks it's tracheostomy? Okay. So we should not attempt tracheostomy, first of all. That is the only thing, that is why I told you that's a trick question. Attempt an intubation. Because I'll tell you why. If you put a tracheostomy, right, through that tracheostomy site, these papillomas will find a way to come out into the skin. Because see, this is a virus. It is in the epithelium. But the intubation will definitely be difficult. It will be a difficult intubation, but try intubating the patient. Because now, if you put a tracheostomy tube and you waste around 5-6 days, the papillomas are going to proliferate through the tracheostomy site. So it should not be done as the primary measure in cases of maintaining an airway. It should be always intubation. Okay, remember that. Okay, fine. Chalo. Now let's move on to the next question. Now I'm going to show you certain important incisions which are used in head and neck surgeries. And you should at least name these incisions whenever you are getting them. What is the name of the incision which we do in laryngectomy? What is the name of the incision which we do laryngectomy? Okay, so this is the neck. This is a suprasternal notch. Right, this is a suprasternal notch. This is your hyoid bone. This is a hyoid bone. These are your sternocleidomastoids. Okay, what is the name of the incision that you are going to give in laryngectomy? So in laryngectomy, we give an incision which is called as 𝐒𝐿𝐴 incision. 𝐒𝐿A incision. Okay, so that is the one which is given here. Okay, now what is this 𝐒𝐿A incision? 𝐒𝐿Aa incision is usually the one which has got two important, it's like a U. It's a U-shaped incision which comes down like this from the anterior border of one sternocleidomastoid to the anterior border of second sternocleidomastoid, and it goes up towards the mastoid tip. So from one mastoid tip, I'll come down like a U and I'll take it up to the opposite mastoid. Okay, so that is what is called as 𝐒𝐿Aa incision. Okay. Now, Adi is asking what are plumes in HPV papilloma surgery? Okay, now remember one thing. Very, very good question. Plumes are generated from when we use laser. Okay, so laser fumes are called as plumes. So that is why whenever we are doing a surgery in respiratory papillomatosis, whenever we have a laser excision for that. So when we are doing a laser excision, it creates a lot of smoke. That fume or smoke that is created is called as plume. Okay, so laser fume is called as plume, and we should not inhale that. So that is why we keep a very big mask as well as goggles whenever we are doing a surgery of papillomas. Okay, remember that, because that could contaminate you. You could inhale that, and that could, lead to a problem inside you. Right? So that is why that is the risk of surgery. That is a good question that you have asked. Okay. Now, is everybody understood what is 𝐒𝐿Aa? U-shaped incision, mastoid to mastoid, comes down, the vertically comes down along the anterior border of sternocleidomastoid, turns and then goes to the other mastoid tip. This is the incision that we utilize for laryngectomy. Okay, fine. So you can see here, this is a laryngectomy incision. It's a complete neck which gets involved. Okay, fine. Now let me come to the second question. What is this incision? And why do we do this incision for? Okay, so there is a name for this incision, which is usually done in cases of parotid surgeries. So when we are doing parotid surgeries, okay, parotid surgeries means when we are doing surgeries for pleomorphic adenoma, we are doing it for mucoepidermoid carcinoma, right? Any parotid lesion, Warthin's tumor, anything. We give this incision for, it's a very cosmetic incision, and at the same time, it gives us better exposure. Now, what is this incision? It's called as a lazy S incision. Lazy S incision, right? Why? Because you can see this is a lazy S, right? Not a very good S, but it's actually got a name to it. It's also called as Blair's incision. Blair's incision. Okay, it's called as Blair's incision or a lazy S incision. Now, this incision starts from the preauricular area. You can see here, it turns beneath the lobule, comes towards the mastoid, and then comes 2 finger breadth below the angle of the mandible in this cervical crease. So see here, see this is my mandible. I always go 2 finger breadth below the angle of the mandible and use my crease here. So I'll take it right from the preauricular area, turn it behind the lobule to the mastoid, then come 2 finger breadth in the same skin crease, 2 finger breadth below the mandible. Now, why do I keep 2 finger breadth below the mandible? Because a very common nerve which can get injured in parotid surgery is facial nerve, and the marginal mandibular branch of the facial nerve runs next to the mandible. So you can't put this incision at the mandible. You have to come 2 finger breadth below so that you can save the marginal mandibular nerve or the branch. Okay, now, one recently asked question that was asked in FMGE actually, that what are the nerves that can commonly get damaged in parotidectomy? What are the common nerves that can get damaged? So there are very important 2 nerves which can get damaged in cases of parotidectomy. One is obviously the facial nerve, because it is running inside the parotid gland between the deep lobe and superficial lobe. So facial nerve, all 5 branches, all the 5 branches. What are the branches? The first branch, which is going up. What are the 5 branches of the facial nerve? Right? Anyone can tell me what are the 5 branches of the facial nerve? So it's temporal, it's zygomatic, buccal, marginal mandibular, and cervical. These are the 5 branches of the facial nerve. Any of these branches can get damaged in cases of parotidectomy. The second thing that can get damaged in parotidectomy is a greater auricular nerve, which is causing its supply to the auricle here. So that is also a very common nerve to get damaged in cases of lazy S incision when we are giving, and that is also something which can get damaged in cases of parotidectomy when we are raising this flap. Okay, fine. Chalo. Now let's come to the next question. What is this incision? Okay, so this incision is usually the one which is given in cases of thyroid surgery. So in cases of thyroid surgery, we give an incision which is called as Coker's incision. Okay, so what is Coker's incision? Coker's incision is a transverse incision, or it's a horizontal incision which is given from one sternocleidomastoid to another sternocleidomastoid, and it is given 2 finger breadth above the sternal notch. 2 centimeter or 2 finger breadth above the sternal notch. We keep 2 fingers over here above the sternal notch. Along the crease, along the skin crease, we give a horizontal incision, and this is called as Coker's incision, which is done in thyroid surgery. So Blair's incision, parotid surgery, Gluck-Sorensen, laryngectomy, and Coker's incision in thyroid surgery. Whatever thyroidectomy we are doing, hemi, total, anything, we'll put this incision. Okay, fine. Chalo, next incision. What is this incision? Let's say this patient came to you post-operatively. Let's say I had operated on this patient. Now, what is this particular patient? What this particular patient has, right? What is this particular incision? So this incision is called as Gluck-Sorensen incision. Gluck-Sorensen incision. Now, if you see carefully, what is Gluck-Sorensen? This incision has been starting from the central area, the mentum, here, the chin, the mentum. It starts from the mentum, then it is curved down 2 finger breadth below the angle of mandible. So it is 2 finger breadth below the angle of mandible, and it goes up till the mastoid tip, right? Like a U. And then we have one other limb to it where we keep this vertical limb downwards towards the clavicle. Okay, so this vertical limb comes down towards the clavicle. Okay, so this is something which is done in cases of neck dissection. This is done in cases of neck dissection. And we call this particular thing as Gluck-Sorensen incision. Okay, fine. So this is something that you should remember, that this is an incision, starts from the mentum, goes up till the mastoid tip like a U, 2 finger breadth below the angle of the mandible, and the vertical limb comes down and up till the clavicle, up till the mid third of the clavicle. That's the vertical limit. We do it for neck dissections, any type of neck dissection, radical neck dissection, be it modified radical neck dissection, supraomohyoid neck dissection, any neck dissection, you will give Schobinger's incision. Okay, sorry. There's a wrong name that I have written over here. Sorry, there's a wrong name over here. I wrote it again. This is called as Schobinger's incision. Schobinger's incision. Okay, my bad. This is called as Schobinger's incision. Okay, this is called as Schobinger's incision. Schobinger's incision is the one which is given for neck dissection. Okay, my bad. In a hurry, I wrote it. Okay, fine. So have you understood about what are the types of incisions? 4 types of incisions you must remember. Gluck-Sorensen for laryngectomy, Coker's for thyroid, Blair's for parotid, and Schobinger's incision for neck dissection. Okay, fine. So this is what you should remember. Okay, chalo. Now, finally, we are done with the larynx questions. Okay, these are the regular larynx images and the larynx questions which are asked to you. Okay, now let me go on to the second aspect as to what is nose. So the difficult aspect is over. Now let me come into a more fun aspect, that is nose. Okay, now inside the nose, they will ask you certain important questions. Okay, and they will show you a lot of images inside, especially the nose questions, right? And what is this nose? What are the structures seen in the nasal cavity? They're going to pop questions from that. Okay, so now this is something. Let's say I'm showing you the lateral nasal wall. Okay, I've gone inside with an endoscope and I'm showing you the lateral nasal wall. Now, what all structures can you see in the lateral nasal wall? You can see this is the area for the septum. This is medial wall of the nasal cavity. This is septum, and this is the lateral side. Okay, let's say you are seeing my left nostril. I'm standing in front. This is my lateral side. This is my medial side. So this will be my septum. This is the lateral side. You're seeing my lateral nasal valve, right? What does the lateral nasal wall contain? What are the contents in the lateral nasal wall? Okay. Now, what you can see over here in the lateral nasal wall, if I draw this lateral nasal wall for you, let me just draw it over here. Okay. Okay, let me just draw the lateral nasal wall for you. Okay. So let's say this is your nose. This is your nose. Okay. This is your septum, which you are seeing medially. This is your septum. Laterally, you have got a turbinate, which is called as inferior turbinate. This is your inferior turbinate, right? Then you have got something called as a middle turbinate, which is coming down like this. Middle turbinate, right? And this is your lateral wall of the nose. This side is lateral wall of the nose, right? Now here I want to make you understand certain important structures, because this lateral wall of the nose is the area which is very important for you to understand osteomeatal complex. This is a very important area where a lot of questions will come. And that is our osteomeatal complex area. Okay, now what is this osteomeatal complex? Osteomeatal complex is an area which is a common drainage site for three important sinuses. PAM. Frontal, anterior ethmoid, and maxillary. These are three sinuses which drain together in my osteomeatal complex. Okay. Now, what is this osteomeatal complex made about? Right. Now, first, let me show you what exactly are the structures that I want you all to remember and see. Now, just imagine if this is my nose, what is here? These are my orbits, correct? So now let me make up the orbit over here. These are the orbits. Okay, this is the orbit. Okay. And you have got one important sinus over here. This is your maxillary sinus. Right? This is your maxillary sinus, which is opening inside this osteomeatal complex area. Correct? Right? So I can simply say that osteomeatal complex is an area which is present between my middle turbinate and the orbit. This little space over here. This is the one, and inferior turbinate also. So you can see inferior turbinate, middle turbinate, and orbit. This little space over here, this is my osteomeatal complex. Correct? Now, there are certain structures within the osteomeatal complex. And now I want to add certain structures within the osteomeatal complex. And what are those structures? Now, let us first identify them. Okay. Now, I told you that this is your middle turbinate over here, right? Okay. Now, the middle turbinate cannot hang down just like this. The middle turbinate attaches to the medial wall of the orbit. See here, it is attaching to this medial wall of the orbit by an important structure, and that structure is called as basal lamella. Basal lamella. So one attachment of middle turbinate is actually towards the medial wall of the orbit. I only want you to understand one attachment here. There are three attachments in total of middle turbinate, but you should remember at least this attachment. This attachment of the middle turbinate towards the orbit or the medial wall of the orbit, that's called as basal lamella. We also call it as ground lamella or basal lamella simply. Okay. Now, why am I telling you this? It will make some sense when I make you understand what are these spaces. Now, there is a bone. There is a bone which arises from the superior part of the inferior turbinate, and it goes above like a boomerang. It goes above like a boomerang. This bone, which is arising from the inferior turbinate and it is going anterosuperiorly, this bone is called as uncinate process. This bone is called as uncinate process. Okay, so far so good. We've understood there is an uncinate process. Now, remember, why this ground lamella has been given. Ground lamella or this basal lamella divides my sinuses into an anterior group of sinus, which open in front of them, and a posterior group of sinus which open behind them. If I talk about anterior group of sinuses, they are these three. FAM, frontal, anterior ethmoid, and maxillary will all open anterior to this basal lamella. So I can call all of them as anterior group of sinus. And my two sinuses, posterior ethmoid and sphenoid, will open behind this ground lamella, and I can call them as posterior group sinuses. Simple, right? So I am in front of this basal lamella towards you. Correct? Now, in front of this basal lamella, there is another important structure, and that structure looks like a huge ball. That actually looks like a ball. Okay. Let me make it in green. This looks like a huge ball in front. So I'm in front of this and putting this huge ball. And this is the largest anterior ethmoidal air cell. And we also call it as bulla ethmoidalis. So in simple words, if I call anterior ethmoidal sinus, or if I call anterior ethmoidal air cell, or simply if I call it bulla ethmoidalis, they all mean the same thing. Bulla is the largest anterior ethmoidal air cell which is present in front of the basal lamella or the ground lamella. Correct? Right? So now you see something, you see an uncinate process, you see this bulla ethmoidalis, right? Let me just make it a little more clear for you. This is your bulla and this is your uncinate. This is your uncinate. Okay? So what all structures are present inside this osteomeatal unit now? You have got uncinate process, you have got the middle turbinate, you have got the bulla. Right? You have got this basal lamella. These are all forming parts of our osteomeatal complex, right? Now important spaces will come. Now think, the maxillary sinus is opening through an opening, and this is called as ostium of maxillary sinus. Ostium of maxillary sinus goes into a three-dimensional space, and this little space which is three-dimensional is called as infundibulum. It's called as infundibulum. Infundibulum goes into a two-dimensional space and this is called as hiatus semilunaris. And hiatus semilunaris goes into the middle meatus. So what exactly is the kahani? You've got an ostium which goes into a three-dimensional space just next to the opening which is called as infundibulum. Infundibulum goes into a two-dimensional space which is called as hiatus semilunaris. And finally the hiatus semilunaris continues as middle meatus, which is a space present inferior and lateral to the middle turbinate. The middle meatus. Right? This is what is the whole significance of osteomeatal complex. It has got these four important spaces. The maxillary ostium going into this three-dimensional space called infundibulum, which goes into this two-dimensional space called hiatus semilunaris, which opens into the middle meatus. So ये पूरी कहानी है. And think, ये कैसे आ रहा है? The uncinate is in front, bulla is behind. So actually this ostium is getting into the infundibulum, coming into the hiatus, and now going into the middle meatus. Uncinate is in front, right? So now let me show you how exactly that space will look like, or what exactly will be the scenario when they give you these questions. Okay, now let me go back to that image. You'll understand that more. Now see this. Okay, now see this. This is your septum, medial, what I drew for you. This is the lateral wall, right? Now in this lateral wall, can you make out certain structures? This is the middle turbinate which I drew for you. The same middle turbinate, right? In front or just next to the middle turbinate, let's say this is the middle turbinate, next to the middle turbinate, there was a boomerang shaped bone. This is what? This is your uncinate process, right? Behind the uncinate process, you have this globular structure, what you are seeing over here. This is your bulla ethmoidalis, correct? And what exactly is happening? This space present lateral and inferior, this is the middle meatus. Middle meatus is going into a two-dimensional space which is present in between the bulla and the uncinate. Imagine uncinate is in front, bulla is behind. That is what? The hiatus semilunaris, which will go more inside to form the infundibulum, which will go more inside to form the maxillary ostium. Did you guys understand what is the lateral wall anatomy? And whole of this is called as an osteomeatal complex. All of these things together. Yeah, that's why the other name for osteomeatal complex is also called as Piccadilly circle. Why? Because if you simply think, there are so many chotu spaces here, right? There's Piccadilly Circus in London. So there's got a lot of small roadways there. And that is why it is also called as a Piccadilly circle. Okay, so if any structure has been given to you to identify here, you can now identify in the lateral wall of the nose. Okay, fine. Chalo. Now, this finishes my lateral wall anatomy, what I wanted to show you. Now, let's come to this. Okay, let's come to this. This is a patient who has got unilateral nasal obstruction. This is the septum. This is the inferior turbinate. Okay, this also patient has got episodes of epistaxis. What is the diagnosis of this patient? It has got epistaxis. Okay, so what will be the diagnosis in this patient? Now, if you clearly see this particular nose, the patient has got a sharp bend, and this bend is going towards the inferior turbinate. This is your inferior turbinate, right? So it's going towards the inferior turbinate. So this shelf-like projection, like something you can keep like a shelf, right? You can keep something like a cup of coffee over it, right? Like a shelf. It's coming out. This shelf-like projection, which comes out from the septum and goes towards the inferior turbinate, This is called as septal spur. This is called as septal spur. Now, always remember one thing. Septal spur is one important type of DNS or deviated nasal septum, which has got higher chances of epistaxis. Why? Because it is sharp. So it will, kind of the vessels will become eroded. As soon as the person will sneeze, there'll be kind of epistaxis which will come out. Also, one more important point. Septal spur usually is very sharp, right? And sometimes it actually, puts pressure over a nerve which is present in our middle turbinate. Okay, there is a nerve which is present in our middle turbinate. Let's say this spur was a little big. So the big spur, like this. And if this septal spur impinges the middle turbinate, it irritates one nerve that is called as anterior ethmoidal nerve. And if it irritates the anterior ethmoidal nerve, there will be hemifacial pain. And if there is hemifacial pain because of anterior ethmoidal nerve compression, we call that particular thing as Sludder's neuralgia. We call that as Sludder's neuralgia. Okay, that's called as Sludder's neuralgia. Okay, remember that. That question also has been asked. Hemifacial pain occurs due to what? Hemifacial pain in DNS occurs due to irritation of anterior ethmoidal nerve in the middle turbinate when the spur is impinging, and that causes a sharp shooting pain on the hemifacial side. That's called as Sludder's neuralgia. Okay, that's all. That's all that you need to remember as far as spur related questions are. What will be the surgery that you can do for this? There are two surgeries. One is called as SMR, submucous resection. One is called as septoplasty. Septoplasty is more conservative. SMR is more radical. Septoplasty is not done before 17 years of age. Septoplasty can be done before 17 years of age. SMR is usually done after 17 years of age. Why? Because it is more radical. Septoplasty, what incision do we give in septoplasty? The incision given in septoplasty is called as Freer's incision, which is a mucocutaneous incision just behind the mucocutaneous junction. We'll give the incision over the cartilage. That's called as Freer's incision. In SMR, we give something called as Killian's incision, which is 5 millimeters behind the mucocutaneous junction. That is called as Killian's incision. Okay, just remember these incision names as far as questions are concerned. Okay, fine. Chalo. Now, so I've already done what are the basic parts. Now let me straight away go into a very important instrument that is utilized in your septoplasty and SMR. And what is this instrument? It has got these flat ends at both the sides. Now this instrument is a very important instrument for you to recognize because this instrument is utilized for raising the mucoperichondrial and mucoperiosteal flaps in cases of SMR and septoplasty. And what is this instrument which is important to raise the flaps over the cartilage and over the bone? This important instrument has got two ends. So we call this as Freer's double-ended elevator. Freer's double-ended elevator. So you can see this is a flat end here, flat end here. It's called as a Freer's double-ended elevator, very commonly utilized in cases of septoplasty and SMR. So this is an identification. Please identify this. Whenever you will be given this question, what is the use of this instrument? This is used for in septoplasty and SMR for raising the mucoperichondrial and mucoperiosteal flaps. Okay, fine. So now this is about Freer's elevator. Is there any other surgery where you can utilize Freer's elevator? Yes, we can utilize Freer's elevator even in raising the temporalis fascia. When we are doing a myringoplasty, right, a surgery for the tympanic membrane, even for raising the fascia, we can utilize this instrument, Freer's elevator, because of the, the dexterity of this instrument that it gives. Now, what is this? This is the nasal speculum, and very rightly said by Adi, this is called as Thudicum nasal speculum. Thudicum nasal speculum. Now, it was after Sir William Lewis Thudicum. It was named Thudicum nasal speculum. And what is the use of Thudicum nasal speculum? It is used for anterior rhinoscopy. Anterior rhinoscopy, which is the examination of the anterior aspect of the nose or the nasal cavity. That's why we call it Thudicum nasal speculum. Okay. Now, remember, Thudicum has got smaller blades. If these blades become a little larger, then the larger or the long blade nasal speculum is called as St. Clair Thompson long blade nasal speculum. Okay, that's called a St. Clair Thompson long blade nasal speculum. That is having a larger blade, but the same kind of body. Okay, it's got the same body, but it's got a little longer blades. Then we call it St. Clair Thompson long blade nasal speculum. Shorter blades, then we call it Thudicum nasal speculum, which both are utilized in anterior rhinoscope. Okay, fine. Chalo. Now, let's come up to the next one. Now, let's say this patient underwent septal surgery. And this is what you see in this patient on post-op day 1. The patient is also having intense pain in the nasal cavity, and the patient is, the patient can't resist that pain. There's so much of pain, and there is also swelling over this area. Now, what exactly is this diagnosis? Yes, everyone is correct. This is septal hematoma. This is septal hematoma. Always remember, septal hematoma is a complication which is very common post septoplasty and SMR. Why? Because whenever we are raising these flaps, right, these vessels can get injured, and whenever these vessels get injured, when we approximate those flaps together, the mucoperichondrial flaps, these can form a hematoma inside, and there will be bilateral swelling. There will be bilateral swelling over the septal area. So there will be bilateral swelling. Always remember they are bilateral, and there will be intense pain. So how will we manage it? What will we do in these septal hematomas? The only way we can manage it is either we aspirate the blood, we have to do aspiration, or we have to do incision and drainage. So put a nick, drain out the blood. Why? Because if you don't do it, it will become purulent, and that might form a septal abscess. It might form a septal abscess. And septal abscess is dangerous. Okay, that is dangerous, and it can even, later on worsen by that infection can travel into the cavernous sinus also, right? Because it is a dangerous area of our face. And that is the reason we incise and drain it and aspirate it, and we give compression over that area. Okay, fine. So this is something that you should remember. Bilateral swellings, if you see post-septoplasty SMR as a complication, we treat it as incision and drainage, and it is a septal hematoma. Okay, fine. Yes, closed compression packing. Srini has told right. So we give a compression packing so that they don't recur back. Okay, chalo. Now, okay, now let me show you certain important things about a disease. Okay, so let's say there was a scenario of a 40-year-old man who came to you with symptoms of foul-smelling nasal discharge, and the patient has got intense amount of crusting inside the nasal cavity. The patient is also not able to breathe properly, and the patient is having anosmia. Now, what is the diagnosis of this particular patient? Okay, you see the nasal cavity inside, and you see this kind of something is there. You see that there's a lot of crust inside, right? And you see that there is some foul-smelling nasal discharge. Yes, Vidya Lakshmi, I think Nishta, Srini, all of you are right. Okay, so this is atrophic rhinitis. Always remember, this is atrophic rhinitis. Okay, atrophic rhinitis will have classical symptoms of green colored crusts. They will have these green colored crust. They will have foul smelling nasal discharge, which is also given the name as ozena. It's also called as ozena, which is foul smelling nasal discharge. At the same time, because their neurons get, the neurons also get damaged in this infection. So that is why they cannot smell their own discharge. The person around them can only smell that discharge. And that is why it's called as merciful anosmia, because they cannot smell their own discharge. So that's why they have got merciful anosmia. And because of this intense crusting, right, even the turbinates inside, right, inside the nasal cavity, they undergo resorption. The bone undergoes resorption of these turbinates, and there is intense bony destruction. So the whole cavity inside in this atrophic rhinitis cases becomes roomy nasal cavity. Roomy nasal cavity. So what all you will see in cases of atrophic rhinitis, you will have intense crusting, foul smelling nasal discharge, which is called as ozena, roomy nasal cavity, which is seen because of the destruction of these turbinates, because of the bony resorption that is happening in these turbinate bones. At the same time, they will have anosmia, which is called as merciful anosmia. Why? Because their neurons get damaged. So only that is a mercy to them that they cannot smell themselves, and only the people around them can smell. That's called as merciful anosmia. It is an infection which happens because of Klebsiella ozeni. Klebsiella ozeni. Okay, and that is the reason why this discharge is called as ozena. Okay, So it's a very foul smelling discharge, happens because of Klebsiella useni, and that is called as atrophic rhinitis. Now, can you all tell me what is the operation done for atrophic rhinitis and what is the medical line of management? How will you treat atrophic rhinitis? What are the things that you will give atrophic rhinitis patients? Okay, let's quickly put up them. What are the treatment plans for atrophic rhinitis? Very good. So first we'll do medical line of management. So medical line of management is the most important is alkaline nasal douching, okay, which contains three important things, which is called as sodium chloride plus sodium biborate plus sodium bicarbonate. Okay, sodium bicarbonate, sodium chloride and sodium biborate all mixed in 280 ml of water. This is usually the one which we help them douche, right? And this douching will help dissolve these crust and help or regenerate this mucosa. That's called as alkaline nasal douching. Very, very important. Other than that, we can also give them 25% glucose plus glycerine drops. Glucose plus glycerine drops. Okay, that is also another solution that we can give them. Okay. Also, there is a solution which we can give them is called as chemicetin solution. Chemicetin solution, okay, which contains chloramphenicol as well as potassium iodide. Also, there has been trials of streptomycin injection. Streptomycin injections in order to counteract the Klebsiella useni, right? Okay. And finally, we can also give them estradiol sprays. Estradiol spray, helping in regeneration of the nasal cavity. Okay, so these are the usual ones, but the most common ones that we utilize is alkaline nasal douche and 25% glucose and glycerine drops. These are the most important ones, right? The most important operation that we do is Young's operation, right? It's called as Young's operation. And what exactly is Young's operation? We put an incision in the mucocutaneous layer and we close the nasal cavity from all the sides. We basically, if this is the nasal cavity of the person, right? We take incisions from the lateral side and medial side, raise flaps, and we close them in the center. And why do we close it? It's just because so that the regeneration can happen inside. We don't want the air currents to go inside, cause more crusting. And that is why this is called as Young's operation. Now later on, we started to modify this operation so that we can have a small hole in the center. That is called as modified Young's. So modified Young's means that we take a small 4 millimeter hole inside this area, so that we can actually push this glucose and glycerine drop and even the douching we can do through this hole. And that also helps in, the patient also will breathe better and the patient will not have any problem. Okay, so that is called as modified Young. If you put a small hole in the center, but if you close it completely, that's called as Young's operation. That is the most common thing that we utilize in cases of atrophic rhinitis. That's all. That's all what you need to know. Okay, fine. Chalo. Now let me go to the next question. There is a patient who has entered inside. Let's say this is a 50-year-old male, right? And this particular patient has complained of certain nodular growths present bilaterally, and these nodules have been causing him respiratory difficulty, and sometimes they also cause epistaxis. Okay? Now, if I show you that this patient, let's say this patient underwent certain treatment, so he got better. Let's say this person did not get treated, so he ended up after 1 year with this kind of a deformity. Now, what are these and what is the diagnosis? Both of them. Very important questions. What are these? Very good. So what is this? This is rhinoscleroma. Okay. Now, what is rhinoscleroma? Rhinoscleroma is a disease of the nose, which is granulomatous disease of the nose. And this particular disease happens because of Klebsiella rhinoscleromatis. Klebsiella rhinoscleromatis causes rhinoscleroma. Rhinoscleroma has got 3 important stages. First stage is called as atrophic stage. Second stage is called as granulomatous stage. And third stage is called as cicatricial stage. Cicatricial stage. Now, the atrophic stage of rhinoscleroma is the same as atrophic rhinitis. So, whatever I showed you, whatever the features I showed you before of atrophic rhinitis are going to be exactly the same for the atrophic stage of rhinoscleroma, whenever this infection will happen. In cases of granulomatous stage, what will happen? This infection will travel down into the epithelium and they will start forming these nodules. Can you see these nodules? Now, how are these nodules described? These nodules are painless, rubbery, reddish blue, and they do not ulcerate. This is the most important point for rhinoscleroma. Rather, they fibrose. They do not ulcerate, they fibrose. This is the most important thing that you see in cases of rhinoscleroma. Okay? So, these are painless, rubbery nodules which do not ulcerate, rather they fibrose. And they are usually bilateral. Okay? So, you can see them. So, you can see these kind of nodules and they will keep growing. Now, if they keep growing, they are going to make the nose very big. And that is the reason, because they do not ulcerate, they usually become very hard to touch. And that is what is called as a woody nose. They will give a woody nose feeling, that it's like a wood. Somebody is touching a wood. Okay? Now, this deformity of when these nodules will become too large, the nose will also become very large. That is called as a Hebra nose deformity. This is called as Hebra nose deformity. So what is Hebra nose? Hebra is a cross between a zebra and a horse. It's called as Hebra. So that is why the Hebra also has got a big nose. So that is why this nose also appears to be very big, because of these granulomas which are forming, because of these nodules which are forming. And this is the reason why it is called as Hebra nose deformity, which is seen in which stage of rhinoscleroma? Granulomatous stage of rhinoscleroma. Okay. Now, what will happen if this particular person is left untreated? If he does not treat himself, what will happen? If this person does not treat, I told you these nodules are going to fibrose. They're going to heal with fibrosis. And if they're going to heal with fibrosis, they are going to cause a very, a very narrow projected out nose. You can see this nose became narrow and projected out. Right? It's going to cause narrowing of the nose. And this narrowing of the nose, this is seen in cicatricial stage. Cicatricial means when they fibrose. Cicatrization. When they fibrose, they heal. So cicatrization means they will stenose everything and they will project out the nose. And this projection of the nose, this is called as tapir nose deformity. So what is tapir nose? Tapir nose is a nose which is projected out, which is seen in cases of cicatricial stage of rhinoscleroma. And if I talk about the granulomatous stage, you see the Hebra nose deformity. These are the two deformities you should remember. And what are the three stages? Okay, right? Now, let me show you. Let me just say that I took a biopsy of this lesion and I saw under the microscope. So what will you see in the microscope? If I go inside the microscope and I'll see classical signs of rhinoscleroma. Right? What are the classical signs of rhinoscleroma? I'll see these kind of foam-shaped cells. These are foam cells. I will see foam cells. Foam cells are macrophages. And these foam cells or macrophages are given the name as Mikulicz cells. When I talk a lot about, rhinoscleroma, this question comes almost in every paper. Mikulicz cells are seen in. So they are seen as foamy macrophages, seen classically in cases of rhinoscleroma. And very rightly said by you that there is also another important thing, which are these kind of blue bodies, and these are called as Russell bodies. Russell body. Now what is a Russell body? Russell body, let's say this is a plasma cell. This is a plasma cell. At one end of the plasma cell, they will have a collection of these antibodies. And these collection of antibodies, we call them as inclusion bodies. So these eosinophilic inclusion bodies, which are aggregates of immunoglobulins, collected at one side of the plasma cell, is called as Russell body. This is called as Russell body, which is classically seen in cases of rhinoscleroma. So this cytoplasmic inclusion bodies, this is inside the cytoplasm of plasma cells, which is an aggregate of immunoglobulins against Klebsiella rhinoscleromatis. Inside the plasma cells, these are called as Russell bodies, and foam cells or foamy macrophages are called as Mikulicz cells. Okay, this is what you need to remember. Now, what is the drug of choice? How do you treat this particular rhinoscleroma? The drug of choice for rhinoscleroma that has been tried is streptomycin, rifampicin, ciprofloxacin. Okay, But the most tried drug is this streptomycin. Okay, so we can give streptomycin 1 gram per day injections in order to reverse this disease. Okay. Now, there is also a solution which we can put over these lesions. So is there any local solution? The local solution is called as acreflavin. Okay, so it helps in regeneration of these mucosas which have been lost by these nodules. So acreflavin local application has found to be useful, right? And even carbolic acid. So carbolic acid application as well as acreflavin application is useful in these cases of rhinoscleroma. Rest all the drug of choices is streptomycin. Okay, fine. So this is what we require to know in rhinoscleroma. Always remember, granulomatous stage we usually don't operate. But if the patient has underdeveloped cicatrization, then we have to do something called as rhinoplasty. Rhinoplasty means we have to repair the whole nasal dorsum. We have to make the whole nose again. And for that, we require rib graft. So we take a rib and we graft it and we reconstruct the whole nose. That's called as rhinoplasty. Okay, fine. So now we have understood about what exactly are the questions that can pop out from this particular chapter. Chalo. Now let's go for another important question which is very closely related to rhinoscleroma. What will be the question here? They will say, 17-year-old boy had a history of swimming in a local pond. And now that particular boy developed a right-sided nasal obstruction together with a strawberry mass and frequent epistaxis. This is the histopathology which is showing here. What is the diagnosis of this particular patient? So what is the diagnosis? Yes, very rightly said. This is a case for rhinosporidiosis. This is a case for rhinosporidiosis. What is rhinosporidiosis? Rhinosporidiosis is a granulomatous disease of the nose which happens because of an infection by an aquatic protystin. So initially this was believed to be a fungus, but nowadays we call it as an aquatic protystin, and this particular organism is belonging to the family of Mesomycetozoa. Mesomycetozoa. And what is the organism? It is Rhinosporidium seaberi. Rhinosporidium seaberi. This is the organism that is responsible for rhinosporidiosis. Right? Now, rhinosporidiosis is basically a condition where granulomatous disease, right? So what will happen over here? Here, once this rhinosporidium will go in, so you'll always get something related to, swimming in local ponds, right? Or a patient or the person has gone to a local body to swim, or tropical climate, something like that. So usually of people of South India, right? Usually belonging from the southern part, they have got a very tropical climate there. So the maximum areas of South India get rhinosporidiosis. It's more common. Also in Sri Lanka, it's very common because of the tropical areas. Okay. So this disease is prominent in southern part of India as well as Sri Lanka. Coastal areas, you'll get a history of local pond swimming. Rhinosporidium seaberi usually, floats around in this dirty water. Now what happens if the patient goes inside this water? This Rhinosporidium seaberi will go inside into the nose. And if it goes inside into the nose, it will start proliferating. And when it starts to proliferate, it forms these structures which are called as sporangia. Okay, which is called as sporangia. So you can see this is a sporangia, right? It grows into a big structure called as sporangia. And these sporangia have got a wall which is called as chitinous wall. They have a wall which is made up of chitin, right? And inside them, inside these sporangia, you can see that there are many basophilic spores. So inside this, they start to proliferate and they start to form spores which stain blue. So these are the spores which are basophilic. So you've got a sporangia which has got a chitinous wall, and you've got these spores which are basophilic which are present inside. Right? Now after one point of time, these spores will become too much that this sporangia will burst out and all the spores will be released. And they will become an infective unit. Right? So that is how the Rhinosporidium seaberi is going to infect us. When it goes inside, it starts to proliferate. When it forms these kind of sporangia, they will form a mass, and this mass will be red in color. You can see this mass will be a red colored mass. And usually this mass will be unilateral, and it will be at the mucocutaneous junction, just at the junction of the nose. That's why you can see here this is at the junction of the nose, mucocutaneous junction. It will not be inside. And this mass will have white dots over it. It will have white dots over it. If you can see carefully, these are white dots over the red mass. That is why we call it as a strawberry-like lesion, because it looks like a strawberry, right? So that is why rhinosporidiosis produces a strawberry-like lesion. Strawberry-like lesion. Okay, and these white spots are actually the sporangia which have formed. Okay, now how will you treat rhinosporidiosis? Rhinosporidiosis is usually treated surgically. We have to remove this mass out, but we have to give a drug. We have to give a drug so that it doesn't come back. So the drug of choice for rhinosporidiosis is dapsone. That is given 100 mg for 6 to 8 weeks for preventing recurrence. This is a question, dapsone. But the major thing is excision. We have to excise it completely from its base, wherever it is occurring from. Okay, fine. So this is all. This is all what you need to know as far as Rhinosporidium seabirei is concerned. Chalo. Now, 16-year-old boy presented to your clinic with unilateral nasal obstruction and you see a grey glistening globular mass in the right nasal cavity. What is the diagnosis? Simple. What is the diagnosis? 16-year-old boy, unilateral nasal obstruction. What is this? Okay, so anyone wants to attempt this? You see a grey glistening globular mass in the right side of the nasal cavity. Yes, this is a polyp, but can you tell me what polyp is this? What is the type of polyp? Is it an ethmoidal polyp or an AC polyp? This is an antrochoanal polyp. So the answer is antrochoanal polyp. Always remember, antrochoanal polyp is a polyp which occurs in younger people. You'll get a younger history. There will always be grey, glistening, prolapsed masses. Okay, right? Now, this is an antrochoanal polyp. Now, where does the antrochoanal polyp arise from? Antrochoanal polyp arises from the maxillary sinus mucosa. Maxillary sinus mucosa. Okay. Now, let me ask you, what is polyp? What is a polyp? Polyp is nothing. It is basically, you can remember it as hop. It is hopping out from the sinuses. You can simply remember it that they are hopping out of the sinus cavity. And if they hop out of the sinus cavity, so that means they are hypertrophied, edematous, prolapsed mucosa of sinuses. So the sinus has got a lining, right? That lining of the sinus is a mucosa. Mucosa is pseudostratified ciliated columnar epithelium. If it gets some insult, it will hop out. So it will become hypertrophied, edematous, prolapsed. And that mucosa will present itself as a lesion, and that is called as a polyp. If it is in younger people, the most common is unilateral AC polyp. Where does it arise from? Arises from the maxillary sinus mucosa. Okay, now, also one important thing. AC polyp does not grow anteriorly until and unless it is very big. It grows posteriorly towards the nasopharynx. Why does the AC polyp grow posteriorly? It's because posteriorly there is a bigger space, nasopharynx, so it grows posteriorly. Second, the maxillary sinus opening is directed posteriorly. Third, if you see, the nasal floor also is going down and posteriorly. Fourth, our inspiratory currents are going posteriorly, which are shifting it. And fifth, our mucociliary drainage system is also happening posteriorly. So 5 reasons why AC polyp grow posteriorly and not anteriorly. Right? Fine. So now did you understand why it grows posteriorly? It doesn't come out, it grows posteriorly towards the choana. Okay. So this is why it is called as antrochoanal. Why? Because it is coming from the antrum of the paranasal sinus or the maxillary sinus and going back towards the posterior choana or the nasopharynx. Okay, fine. Now, what is the most common reason for formation of AC polyp? AC polyps are usually formed because of infection. So repeated infection of the sinus mucosa can lead to formation of AC polyps. Okay. How will you treat AC polyp? AC polyp has got no medical line of management. If a person has AC polyp, we usually has to undergo PES. PES is functional endoscopic sinus surgery. So we need to take it out. No medical line of management is there for AC polyps. Surgery is the only thing that we can do. Okay, fine. These are the related questions which can be asked in cases with polyps. Now, one more thing is, polyp, always remember, polyps do not pain. They are painless, right? They are painless. They do not bleed on touch. They are insensitive to touch, insensitive to pain, does not bleed on touch, and you can actually move the probe all around the polyp. If you take a probe, you can move all around the polyp. So that is why these are the things. If you are given a question, Just find out that if they are asking you these questions in that. If they are telling you it is not bleeding on touch, compressible, soft, can move the probe all around, does not bleed on touch, does not pain, it is a polyp. Okay, yes, Vidya Lakshmi, dot sign is positive, which is a radiological sign. Now, this is a radiological sign. I have discussed that in my radiological lecture. Okay, so you can just see that where I have discussed the scan of AC polyp. Okay, so you can see how the radiology is read. Okay, but did you guys understand what are the questions or probable questions from AC polyp? Right? Now, let me show you the other one. Now, let's say this is a person, a 45-year-old male with bilateral nasal obstruction. There is bilateral multiple glistening gray masses. Multiple gray glistening masses. What you can see. So now bilaterally, what do you see? Multiple masses. What is the answer here? Okay. So this becomes ethmoidal polyp. So unilateral polyp, antroconal polyp, unilateral arising from maxillary sinus. Ethmoidal sinuses gives out ethmoidal polyp. So this is also HOP, hypertrophied edematous prolapsed mucosa of the ethmoidal air sinuses. Simple, the same HOP, right? So it's a sinus mucosa which is hopping out, right? It's become hypertrophied, edematous, prolapsed because of certain insults. And the most common cause of ethmoidal polyp, like infection was the most common cause of AC polyp, the most common cause of ethmoidal polyp is allergy. Allergy is the most common cause for ethmoidal polyp. Always remember, they will be bilateral. They will occur in middle age group. And they will have a grape-like appearance. You can see here, bilaterally, you can have multiple polyps and they appear gray and, grape-like. Okay, fine. So these are the various things that they can ask you. Obviously, for ethmoidal polyps also, we have to do surgery. But here, in these cases, we give a medical management too. So in ethmoidal polyps, because it is happening because of allergy, right? So we have to give certain medical line of management too. So what is the medical line of management that we give in these cases? The medical line of management usually is number one, antihistamines, because of obvious reasons, because it is allergic. Second is nasal steroids, okay, which usually involve fluticasone or mometasone. A short course of antibiotics, which is usually clarithromycin. Okay, and you can even try oral steroids. You can even try oral steroids at a shorter duration. So what will it do? All these medical line of management will shrink the polyp. They will cause polyp shrinkage. And polyp shrinkage will be helpful to us whenever we are doing a surgery. Because the larger things to take out is much more problematic. We'll end up in more complications. So smaller things, obviously, we'll first give a 2 to 3 months of medical line of management, shrink these polyps, and after that, we'll do FES, or functional endoscopic sinus surgery. Okay, fine. Now we understood what is the important thing for polyps, right? Chalo. Now let's come into another type of more disastrous situation that can happen in cases of nasal disorders. Now this is a person who is a diabetic, and this diabetic patient developed crusting and blackening inside over in the nasal cavity. The nasal cavity started to become black. They also noticed that this black is extending to the face. Okay, they ran to the surgeon, and this has happened only in 10-15 days. They ran to the surgeon, and the surgeon saw that there are these black colored crusts which are seen in the nasal cavity. And when he opened the mouth, he also saw that there is these kind of crusting as well as palatal, blackening that is happening. There's slough that is present over in the palate. What is this? Very right, very good. So this is mucormycosis. Always remember this. Okay, whenever you see something black, think of mucormycosis. So mucor is a fungus which is angio-invasive. Mucor is angio-invasive. Okay, it's angio-invasive. It spreads through blood vessels. Okay, and because it spreads through blood vessels, it causes necrosis, and that necrosis causes these black colored crusting to form. So usually they don't just involve this nose. They involve the orbit. They involve even the cerebral hemisphere. That is why we call this particular disease as rhino-orbitocerebral mucormycosis, or we also call it ROCM. We also call this as ROCM, rhino-orbitocerebral mucormycosis, because all of these sites can get involved, because nose is the epicenter. And if it grows down into the palate, because the floor of the nose is the palate, right? The hard palate, they can also cause palatal perforation, right? Because they are angioinvasive. Okay, fine. So these are sick patients. They come with, whenever they come with these things, we have to first debride them. So we have to take them up for surgery. We have to take out all these crusts wherever they are going, and we have to completely debride them. We have to completely see what is normal and remove the abnormal. And then after that, once they have undergone endoscopic debridement, if the whole face is involved here, then sometimes we need to even remove the whole maxilla, the whole eyeball. Right? That's called as total maxillectomy with orbital exentration. Completely we need to remove it out. After that, so that it does not come back, we need to give them high dose of certain antifungals. Now, what are the antifungals which are commonly used in mucormycosis? It is liposomal amphotericin B, drug of choice, amphotericin B. Also, we can give posaconazole, or ivasuconazole. These are the three drugs which have been tried because we found a surge of mucormycosis during COVID era. And because in COVID, we used a lot of steroids. And steroids are a double-edged sword. Steroid, what do? They lower our immunity. Whenever you give steroids, be very careful, because steroids lower the immunity of the patient. They also raise the blood sugars. So if there is transient hyperglycemia, what will happen? The moment there will be hyperglycemia, this fungus loves immunocompromised states. So that is the reason diabetic people, those people who are on dialysis, right? Those people who are on immunosuppressants, they are the maximum targeted people by this fungus. Okay, fine. Yes, Vidya Lakshmi, we give Weber-Ferguson incision, we give for total maxillectomy. Correct. That is the answer, Weber-Ferguson. Okay, fine. So this is about what you require to know about what is mucormycosis, right? Chalo. Now let me show you another important thing. This is a, let's say, 40-year-old male who has presented to you with blackening of mid-third of the face. This all face, the mid-third of the face has completely become blackened and necrotic. And his eyes also have started to get involved. What is this case? Okay, now think. He has got epistaxis. He has got nasal discharge. He has also got ophthalmoplegia, blurring of vision. And he has got all this area, the mid-third of the face has become black. So I told you one black is mucormycosis. But now here, only the mid 1/3 of the face is black. What is this diagnosis? Any one of you? 100-mark question. Profit question. So what is this? Cavernous sinus thrombosis won't have blackening. Cavernous sinus thrombosis, there will be swelling over the eyeball, proptosis, edema. Okay. There will be signs of meningitis, but they won't have blackening. Aspergillosis, no. This is also not aspergillus. Okay. This is called as NK T-cell lymphoma. NK T-cell lymphoma. Okay, this is a very rare disease. But what I want to tell you is, don't get confused. Every time black means mucor is not the right thing. Black is mucor. It spreads everywhere like this. That's why I told you rhino-orbitocerebral. It'll go in this direction. But if you're having solely the mid 1/3 of the face getting destroyed, there's complete destruction of the mid 1/3 of the face, then the answer would be NK T-cell lymphoma. This is a variety of non-Hodgkin's lymphoma. So you have got non-Hodgkin's lymphoma. This is a rare variety of non-Hodgkin's lymphoma. It is also called as extranodal T-cell lymphoma. Also called as extranodal T-cell lymphoma, non-Hodgkin's lymphoma, rare variety, or you can call it NK T-cell lymphoma. What does it produce? It produces mid 1/3 of face destruction. Mid 1/3 of face destruction. Okay, this is a very bad disease. Okay, this is something which is extremely horrible to have. And obviously, these patients have got a very high mortality too. Almost 70 to 80% of the patients don't make up even in 1 month because it is very rapidly spreading. Now, one virus has been closely related to be seen to this NK T-cell lymphoma, and that virus is Epstein-Barr virus, which is closely related to this. Okay, to this particular disease, right? Now, whenever a person comes to us with this, usually what we do, we debride it. We do something called as debridement, or we take out the necrotic tissues. Together with that, we have to start the patient on chemotherapy, because obviously it's a variety of non-Hodgkin's lymphoma. So chemotherapy for NK T cell lymphoma is usually given by a regimen called as SMILE regimen. SMILE. You can remember this. It's a mnemonic, SMILE. We'll use 5 drugs. What are they? Steroids, methotrexate, ifosfamide, L-asparaginase, and etoposide. These are the 5 drugs which you can utilize. This is called as a SMILE regime, which is usually given in these cases. Okay, and obviously debridement is a thing that we need to do. But because this is, you know, very near the cerebral hemisphere, very near the eye, that is why this has got a very high mortality. Okay, fine. So now you guys understood what are the 2 black things that you need to understand, or what you need to remember, right? Okay. One thing just I need to add on here is, just check out on the radiological segment. I have given that also in the radiology. A very recently asked question is, in mucormycosis MRIs, what sign do you see? So in mucormycosis, the middle turbinate turns black. Okay, so that's called as a black turbinate sign, which is very common on an MRI when you do in mucormycosis cases. Okay, that's a very recent question that has been asked. That is why I have given you that. Okay, fine. Chalo. Now, finally, you have now come out of these lesions. Okay, now let's come to something more important, which they ask. Now, there was a patient who underwent a road traffic accident, and this patient came to the emergency. And now, whenever the patient bends down, he starts having this kind of dripping of something, some fluid. Now, this dripping of this fluid, when it is put on a blotting paper, the blood stays in the center, but there is a fluid which comes out at the periphery. So that yellow colored is the fluid and the blood stays in the center. Yes, the answer is CSF rhinorrhea. CSF rhinorrhea is a condition where you have got CSF leak from the base of skull into the nose. Now, there are certain signs for CSF rhinorrhea. The first sign is seen in traumatic CSF rhinorrhea. Traumatic means they have got blood mixed with CSF. If you take a blotting paper and just put that 1 drop, blood is heavier, it will stay in the center. The CSF is lighter and it will go towards the periphery. This is called as diffusion chromatography. Right? Diffusion, it will diffuse to the periphery. Diffusion chromatography. And this is also called as target sign. It looks like a target. It's also called as target sign. That is the first important thing, what they will ask you. Second important thing is, when the patient will bend down, he will start dripping off CSF. This sign is called as what? This is called as a teapot sign. Like you're dropping tea into the, into that cup. So when you drop tea from the kettle, it is like this, right? So this is called as teapot sign. Teapot sign. Very important question. Right? Okay. There is another important sign, what you see in CSF rhinorrhea. And what is that sign? If you take a handkerchief and if you clean CSF will not crumple your handkerchief. Right? Because CSF does not have mucus. But if there is nasal discharge, that mucus will come over the handkerchief and the handkerchief will become hard or stiff. So CSF does not stiffen the handkerchief. Nasal discharge stiffens the handkerchief because nasal discharge has got mucus. And that is why that CSF does not crumple the handkerchief. We also call it as handkerchief sign or handkerchief test. Okay, that is also another important sign. Now, fourth important sign of CSF rhinorrhea is called as reservoir sign. Reservoir sign is what? When the patient is sleeping, right? The sinuses, mostly the sphenoid sinus, will act as a reservoir for the CSF to collect. And when the patient will get up, because of gravity, all the CSF will start to drop out. So the sphenoid sinus will act as a reservoir for the CSF to collect, and the patient will get up. Because of gravity, all the CSF will come out. This is called as reservoir sign of CSF rhinorrhea. 4 important signs: target sign, teapot sign, reservoir sign, handkerchief sign. All of these signs are questions. Okay, fine. Now, one important question from investigations. What is the best laboratory diagnostic measure for CSF rhinorrhea? If you collect this fluid and send it for laboratory investigations, the best is beta-2 transferrin. So beta-2 transferrin is the best if it is present in CSF. That means it is CSF rhinorrhea. This is the only thing which is present in CSF. It is created by a choroid plexus. So that is where CSF is getting created. So if there is presence of beta-2 transferrin in that liquid, it is significant for CSF rhinorrhea. Now there are better techniques for identifying CSF and more specific and sensitive than beta-2 transferrin is what? This is what is your question. It is beta trace protein. So if you are given a question where both the options are given to you, beta trace protein is more sensitive and more specific than beta-2 transferrin. Beta-2 transferrin has got 97% sensitivity, 99% is seen in beta trace protein. So these are the two important line of laboratory investigations which we rely on whenever we have CSF rhinorrhea. What is the best radiological technique to find CSF rhinorrhea? It is CT bar MR cysternography. Investigation of choice to see where the CSF rhinorrhea is coming out from. CT or MR cysternography, where we'll see the exact leak which is coming out. Okay. Laboratory diagnostic measure, beta-2 transferrin as well as beta trace protein. And these important 4 signs. These are the most important questions what they have asked you in CSF rhinorrhea. Okay. So are we clear now? Right? Are we clear about what exactly are the possible questions from CSF rhinorrhea? Right? Okay. Now, if you get a CSF rhinorrhea case, what will you do? CSF rhinorrhea case, don't jump into directly treating CSF rhinorrhea. We never just jump and treat CSF rhinorrhea. We always take around 14 days to give conservative management. So 14 days we give conservative management where we tell the patient to rest. So we have got resting, okay? And we elevate the head end of the patient by 45 degrees. The second is we give the patient stool softness so that the constipation is relieved. The patient does not put any pressure. We tell the patient not to put up any heavy load so that the strain does not increase or the intracranial pressure does not increase. The fourth important thing that we tell the patient is to take antihistamines so that the patient does not sneeze. Fifth important thing we tell the patient is that start taking acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor. It will inhibit CSF production from the choroid plexus. So around 250 mg twice a day is the starting dose for acetazolamide, which we give it for the first 2 weeks. Okay, fine. So this is something that we always do in cases of CSF rhinorrhea. Now, if we have CSF rhinorrhea medical management which fails after 14 days, then we go for surgical line of treatment. So what is the surgical line of treatment? If suppose this is the defect of CSF rhinorrhea, we have to put multiple layers over this in order to close the defect. Multiple layers. And what all multiple layers we can use? We can use abdominal fat, we can use fascia, we can use cartilage, we can use mucosa, right? We can use gel foam, we can use Surgicel, anything. But at the same time, we put multiple layers, we stack it up. We also call it as a sandwich technique. We sandwich it up and we close the defect. So remember, first 14 days, conservative management, whatever I told you. Next is surgical management, where we do endoscopic approaches and we do a sandwich approach where we keep multiple layers of whatever elements I told you. Okay, fine. This is what you need to understand about CSF rhinorrhea. That's all. That's all what the questions are. Chalo. Let's go on further. Now, let's say 45-year-old male came with unilateral nasal obstruction. The patient also had got epistaxis. Nasal obstruction, epistaxis, unilateral lesion. You went and did a diagnostic nasal endoscopy. You saw that this particular mass is having certain projections. ऐसा दिख रहा है. What is this diagnosis? 45-year-old male, remember that. Unilateral nasal obstruction. Yes, very good. It's inverted papilloma. Now, be very careful in these. Okay, yes, it is Ringer's tumor. Shabash. So now, what exactly is this? If I tell you a 16-year-old boy with unilateral nasal obstruction, grey glistening globular mass, it has to be AC polyp. If I tell you a 45-year-old male, because this is between 40 to 60 years of age, and you have got multiple, this kind of an arrangement, you've not a smooth mass, you've got a mass which is coming out like this. Now, this is called as frond-like appearance. It's like a frond, multiple projections. It's called as frond-like appearance. Now, this is called as inverted papilloma. It's a benign intermediate neoplasm, which has got a malignant potential. It is a benign lesion, but it has got a malignant transformation. Okay, now, inverted papilloma, the other name is also called as Schneiderian papilloma. Schneiderian papilloma. Also given the name as Ringer's tumor. Okay, because Ringer's actually got this tumor, so we call it as Ringer's tumor. Schneiderian papilloma, why do we call it? It's because it arises from the Schneiderian membrane. And what is Schneiderian membrane? Schneiderian membrane is the membrane which is present inside our maxillary sinus and our basically the nasal cavity. That is the epithelium of the nasal cavity and the maxillary sinus is called as Schneiderian membrane. And what is Schneiderian membrane? You've got the pseudostratified ciliated columnar epithelium, right? Which is lining our inside maxillary sinus as well as the nasal cavity, right? So you've got a layer of this pseudostratified ciliated columnar epithelium, right? These are the pseudostratified ciliated columnar epithelium, which are present, right? Why do we call them pseudostratified? Because we have nucleus at different level. So they appear to be stratified, but actually they are not. So this is the side which is coming out from the lateral nasal wall as well as the maxillary sinus, and below them is the bone, right? Below them is the periosteum. You see in the maxillary sinus below is the bone, nasal cavity also below is the bone. So below is the bone, below is the bone, correct? So this two lining of the bone as well as the pseudostratified ciliated columnar epithelium together are called as Schneiderian membrane. If papilloma occurs in them, it's called as inverted papilloma or Schneiderian papilloma. Now, why do we call it inverted? The same reason is because simply think if any tumor comes out, it comes out in this direction. Inverted papilloma doesn't come out this way, outward. Inverted papilloma lining grows inwards towards the bone. It will grow inwards towards the bone. Right? It will go towards the bone. So what will happen? This is an inverted shape. And that is why it is called as inverted papilloma. Okay, now did you understand? What is the most common site for inverted papilloma to arise? Most common site is the lateral wall of nose. It arises from the lateral wall of nose. Most common site of occurrence. Okay, fine. So now have you understood about why inverted papilloma is happening and what is the site? Most common is lateral wall of nose, which contains the Schneiderian membrane, which is pseudostratified ciliated columnar epithelium together with this bone, right? Or the osseous component, right? Now, very important point. So I told you the symptoms: unilateral nasal obstruction, mass which is irregular, 45-year-old male. So I'm talking about 40 to 60-year-old males, not female, male more common, and they will cause epistaxis. So the answer would be inverted papilloma. Okay, now there is a way to stage these tumors, and the staging of these tumors was given by Cruz. So that is called as Cruz staging of inverted papilloma. Okay, there is something called as Cruz staging of inverted papilloma, which are of 4 types. First is, if the inverted papilloma is present inside only the nasal cavity. If it is only inside the nasal cavity, it is stage 1 of Cruz classification of inverted papilloma. Stage 1 means only nasal cavity, only inside the nasal cavity. So let me just draw it over here. Let me just take it out. Let me just take out this. And let me just explain you. It's a very simple staging, but it has been asked as a question. This is your nasal cavity. This is your inferior turbinate, middle turbinate, and this is your maxillary sinus. This is your orbit. Okay. So now, if the tumor is inside the nasal cavity only, we call it stage 1. Okay. Now, what is stage 2? Stage 2 means that now the tumor will involve the osteomeatal complex, which I just spoke about. This is the area for osteomeatal complex, correct? As well as the medial wall of maxillary sinus. See, the medial wall of maxillary sinus is involved. And I told you what is behind. You've got a very important structure here also. That is your bulla ethmoidalis. So the bulla also is involved. Bulla also will be involved. I just now told you, right? So if there is involvement of anterior ethmoidal sinus or the bulla, medial wall of the maxillary sinus and the osteomeatal complex, we will call it as stage 2 Cruz. Simple, right? Now let's come to stage 3. So what is here? This is a medial wall of maxillary sinus, osteomeatal complex, and anterior ethmoidal air cells. Stage 2. What is stage 3 of Cruz classification? If this tumor spreads and involves superior wall of maxilla, lateral wall of maxilla, inferior wall of maxilla, anterior wall of maxilla, posterior wall of maxilla, all other walls of maxilla, lateral, inferior, superior, anterior, posterior, any wall if it is involved. And if there is involvement of frontal sinus or sphenoid sinus. So if there is frontal sinus, sphenoid sinus, any other wall of the maxillary sinus gets involved, we will call it as stage 3. And stage 4 means extra sinus involvement. That means now the whole tumor has come out of the sinus as well as the nose. That means it could go into the orbit, it could come out through the skin, right? Any place other than the nasal cavity and sinuses, then we call it as stage 4. So extra sinus, extra nasal cavity involvement, stage 4. Is everybody understanding what is the Kruse classification, right, of inverted papilloma? Fine. How will we treat it? Excision is the treatment. And what procedure do we do for excision? We do something called as endoscopic medial maxillectomy. Endoscopic medial maxillectomy is the treatment of choice for these tumors. Okay, fine. So endoscopic medial maxillectomy is a treatment of choice, right? So are we understanding about what exactly is this, right? Is everyone clear on what are the aspects of inverted papilloma? The probable questions what can come? Now, the association of HPV has been closely related with inverted papilloma, but till now, still the pathogenesis are unclear. We still don't have an answer as to why it occurs, but most commonly it has been associated with HPV viruses. Okay, or human papilloma virus. Fine, chalo. Now, let us come to another diagnosis, another important thing, right? Still we are in nose, you have to go to the ear. Lot of things to do. Okay, now, you have got a mass. Let's say this is an 18-year-old boy who came with nasal mass with epistaxis. Okay. This epistaxis is profuse, it is unprovoked, it is spontaneous, and it resolves on its own after some time. He bleeds a lot. Okay. When you do an endoscopy, you see a very vascular mass inside the nasal cavity. What is this? Yes, this is angiofibroma. Remember this line, what I told you. Young boy. This is a predominant disease of young adolescent males. So if you have any question which deals with nasal obstruction in a young adolescent male with epistaxis, which is profuse, the answer has to be JNA or juvenile angiofibroma. Now, why do they bleed a lot? It's because if you see inside, they have got fibrous trauma. They've got a lot of fibers. They've got fibrous trauma. But at the same time, if you see, they have got a lot of vessels, and these vessels does not have a smooth muscle coat around them. These vessels do not have a well-defined smooth muscle coat. And their capillary lining, these capillary linings, they have got ill-formed endothelial cells. The endothelial cells are very, very far. So because of the lack of smooth muscle coat and the endothelial cells are not present, in continuity properly, what do these do? They are very fragile. So whenever the bleed starts, they cannot contract and close them. They cannot cause vasoconstriction. And they keep, going loose, and that is why they keep bleeding. That is why you have got JNAs which bleed a lot. Now that is the question that they will ask you. What is one thing or one investigation which you will not do in JNA? What is one thing which you will not do in JNA cases? What is that question? What is that answer? You will never biopsy these patients. Never biopsy JNA. Why do you don't biopsy JNAs? It's just because if you just touch this tumor and biopsy these vessels are lacking a smooth muscle coat and they will start bleeding and it will be like hell and you will not be able to do anything at that particular point of time. Never touch JNAs. They are angry tumors. Okay, fine. Now, next question that comes with JNA probability is that what is the source where JNA is coming from? Which is the site of origin for JNA? What is the site where the JNA is coming from? What is the site of origin? So it is the superior lip of sphenopalatine foramen. So the superior lip of the sphenopalatine foramen is the area where this site which is a site which causes JNA formation. Okay. Now, why does that happen? So there is recently a theory which has been proposed that there are certain vascular remnants of the first pharyngeal arch. So you have got maxillary artery, which is the first pharyngeal arch artery. There are certain vascular remnants which remain in this sphenopalatine foramen. And these vascular remnants, under the effect of testosterone, because they have got certain receptors or androgen receptors, under the effect of testosterone, it starts to proliferate as a tumor, and that tumor proliferates as a big mass in the nasopharynx, which later on comes into the nasal cavity, and we call it as JNA or juvenile angiofibroma. Okay, so don't forget about the adolescent male and profuse epistaxis and this question. These two questions are the most important which have been asked again and again. And obviously about the vessels. Okay, why do they bleed a lot? Okay, fine. Chalo. Now, 6-year-old child came to your OPD with symptoms of mouth breathing and snoring. And you saw this kind of a face. What is the diagnosis of this child? How will you tell that this is the child of this particular disease? Okay, so what is this child? How will you diagnose and what will be the diagnosis of this child? Anyone? Yes, this is adenoid hypertrophy. Correct, Sanskar. This is adenoid hypertrophy. So adenoid hypertrophy is creating a face which is called as adenoid facies. It's blocking the nasopharynx and it's causing something called as adenoid facies. So now if you see here, this is an open mouth. So these people will have open mouth or mouth breathing. They will have crowded upper incisors. Crowded upper incisors. Why? Because their mouth will keep open. And tongue is very important to mold your teeth. Tongue, stimulates your gums and takes your teeth out. So these children never put their tongue towards the gums. So obviously, whenever the teeth come out, they'll be very crowded. That's why they have got these crowded upper incisors. Now they don't use their nose a lot. So that is why they will have pinched out nose. Pinched out nose. Okay. And why is the nose pinched out? Because their ala is atrophied. Because their ala has atrophy. So there is alar atrophy. Okay. Now, if you see, because their mouth is always open and the crowded incisors are coming out, so their lip will become pinched up. So there is a pinched up upper lip. Okay. There's a pinched up upper lip. Their face is abnormally elongated. Why? Because they are mouth breathers. So they have been breathing from the mouth. So their mandible becomes elongated. Maxilla remains small. So their mandible is elongated. And the maxilla remains small or hypoplastic. That is why it's called as long face syndrome. Their faces are very, very long. And that is the reason why it is called as long face syndrome also. These adenoid babies. Okay. Now, at the same time, they will have a very dull expression. They will have a very dull expression. And why is that the dull expression comes? Why? Because they are having sleeping difficulties, right? They are snoring. They are not sleeping well. And because they are not sleeping well, they are tired when they get up. Okay. At the same time, their school performance will also drop down. Why will the school performance drop down? It's because they will develop conductive hearing loss. In the nasopharynx, you will also have eustachian tube openings, which will block by the adenoids, and that is why they cannot hear their teacher. And also, the second reason why their school performance is down is because of carbon dioxide retention during sleep. So when these children are sleeping, they are not getting enough oxygen because they are snoring, right? They are not getting enough oxygen. They are not nasally breathing. And that is why it causes carbon dioxide retention. Carbon dioxide causes clouding of memory. And clouding of memory that is created by carbon dioxide, it causes these children to drop down in school performance. And we call that term as Guy's aproxexia. What is Guy's aproxexia? Is inattentiveness. They are not very attentive in class. Okay, fine. So see how many problems can be related to one adenoid child, right? So this is what is the general things that you need to know as far as adenoids are concerned. Okay, fine. Now, you have got a patient who had got a missed out foreign body some 3 years back. Now the patient comes up with epistaxis and unilateral nasal obstruction. What is the diagnosis? What do you see here and what is the diagnosis? The patient has a significant history of a missed out foreign body which he never got removed. Okay, so what is this? What can you see over here? What is this yellowish thing, what you can see here, right? So this seems like a calcareous lesion. This seems like a calcareous lesion. Okay, calcareous means something which has, which has got some ragged edges, right? Like a stone-like lesion. Now this is, it's not a granuloma. This is a rhinolith. This is rhinolith. What is lith and what is rhino? Rhino means nose, lithos means stone. So this is a stone-like lesion. Can you see? This is a calcareous stone-like lesion. So I told you the crux of it is in the history that they will be having a missed foreign body. So what happens is, if there is a missed foreign body, or even if there is inspissated mucus, okay, a lot of mucus is there, we call it inspissated mucus, or let's say a lot of blood is there, or let's say a blood clot is there. What happens in the nasal cavity is, long-standing blood clots and long-standing mucus and long-standing these foreign bodies, if they are remained and nobody has taken them out, so what will happen? There will be deposition. There will be deposition of calcium and magnesium salts around them. So calcium and magnesium salts start to deposit around them. If calcium and magnesium starts to deposit around them, they will form a stone-like mass. And that stone-like mass will be unilateral, and it will cause epistaxis. Why? Because it has got these edges, right, which are coming out. So it will, these edges will cause trauma to these nasal cavity mucosa, and that will cause bleeding. So unilateral nasal obstruction, unilateral epistaxis, together with this calcareous lesion, the answer would be rhinolith. Remember that. Okay. How will we treat it? We will have to remove it. So if it is a small rhinolith, we will remove it in toto. In toto matlab ek saath nikal liya. If it is a big rhinolith, then we will remove it in piecemeal. We'll again, we'll cut it into several pieces and we'll remove it in a form of piecemeal surgery. Okay, piecemeal, the form of pieces. Okay, fine. So this is about what exactly you need to know about rhinolith. Okay, chalo. Now let's come to another important line. Okay. Now this line is a very important question. If we draw an imaginary line from the medial canthus to the angle of mandible, like this, from the medial canthus down to the angle of mandible, if we draw an imaginary line, this line is called as what line? This line is called as Orngrens line. This is called as Orngrens line. Okay. Now what is Orngrens line got to do? Orngrens line is a very important line for paranasal sinus tumors, especially the maxillary tumors. So see, this is your maxilla, right? This is a maxillary tumor. Now, below this Orngrens lines, if anything is there, we call it infrastructure. Infrastructure. And above this Orngrens line, we call something called as suprastructure. Suprastructure. If there is any tumor, especially the maxillary tumors, which are above this line or in the suprastructure area, they have got very poor prognosis. Correct, as you told Gagan. It has got very poor prognosis. And if it is below this line, it has got good prognosis. So surgically, we can treat these infrastructure tumors better than suprastructure tumors. Okay, remember this line, very important question. It is called as Orngrens line. Okay, chalo. Now, child is born and this particular child has got cyclical cyanosis. Cyclical cyanosis. Cyclical cyanosis means what? Bachcha rota hai, phir bachcha sota hai. That is what cyclical cyanosis is. That means the child, see, when children are born, right, neonates are obligate nasal breathers. Obligate nasal breather ka matlab, children can only breathe from the nose. They don't know how to open the mouth and breathe. Why? Because their larynx is very high placed. So they cannot open their mouth and breathe. Now at the same time, if children are obligate nasal breathers, this child only cries and suddenly gets some air and his cyanosis reverses. The moment he closes the mouth, the cyanosis comes back. What is this? Yes, everyone is right. This is choanal atresia. This is choanal atresia. You can see that this is closed. One part of the nasal cavity is closed. Now, if one side is closed, we call it unilateral. If both are closed, we call it bilateral. Obviously, bilateral choanal atresia is something which is an emergency because the child will be cyanosed since birth. Unilateral, we can wait. We usually see the symptoms after 1 to 2 years. But this is something which is seen at birth itself. Okay? Now, if the person is having choanal atresia, there is a very important syndrome which is associated with choanal atresia, and that is called as Charge syndrome. Charge syndrome has got association with choanal atresia. C is for coloboma of the iris. H is heart defects. And the most common heart defects which are seen with Charge syndrome is conotruncal abnormalities. Conotruncal abnormalities. A is again for atresia, which I already told you. R is retarded growth. G is genital anomalies, and E is ear anomalies. So G is for genital anomaly, E is for ear anomalies. These are all associated with CHART syndromes. Atresia is a very common thing associated with CHART syndrome. And that is the reason if you have an atretic child, we have to work up for CHART syndrome as well. We need to find out if there is any problem in the CHART syndromes, right? We need to do a complete body workup. Okay, now, if the child is not breathing since birth, right? How will we make the child open the mouth? Because see, there is some time we will operate. We will take some time to operate on, right? We cannot just operate the child. So for buying time, we need the child to open the mouth. How will we open the mouth of this child? So what do? We take a bottle nipple. We take a bottle nipple. We take a nipple of the bottle, right? This is a nipple, right? And we cut open the end of the nipple. We cut open the end of the nipple. And we attach this nipple by these bands. We attach 2 ribbons around this nipple. And we put this nipple end inside the mouth of the child. And we tie these bands at the occiput. This technique, very rightly said by Vidya Lakshmi, is called as McGovern's nipple. McGovern's nipple. Very, very important. So they will give you this clue that what is this? This is McGovern's nipple technique, which is done in babies of corneal atresia so that they can open their mouth and breathe. Okay, so this is a very, very important question. Later on, obviously, even if it is unilateral or bilateral, we need to do a surgery where we perforate this or we basically, recanalize. What is the right word? We recanalize the nasal cavity. Okay, fine. Right. Now, one important question, last one. Why exactly this corneal atresia happens is because of the persistence of bucco-nasal membrane. Persistence of bucco-nasal membrane. So this is a membrane which is present between our nasal cavity posteriorly and oral cavity. And usually this membrane disappears, so that our oral cavity and nasal cavity have got a connection. But if it persists, then obviously it will be completely closed. And that is the reason why these particular children have got cyanosis when they are born, right? When they have corneal atresia. Correct? Okay. Now, can you identify this? What is this? What is this? This is something which is asked out recently. What is this particular thing? And we can use it inside in the nose also. Okay. So this particular thing is made up of hydroxylated polyvinyl alcohol. Okay, so hydroxylated polyvinyl alcohol is something what this particular material is made up with. But what exactly is this which we are keeping inside the nasal cavity? Okay, so this is called as a merocell pack. This is called as a merocell pack. It is made up of hydroxylated polyvinyl alcohol. And this is a very common thing nowadays we utilize in epistaxis control. Okay, so gone are the days we have got this epistaxis control where we put these ribbon bandages. We are using ribbon bandages only in areas where we don't have these packs. These are ready-made packs. And you can see they have got one kind of a thread hanging out at one end, right? So what do? We just insert these packs directly inside into the nasal cavity. Okay, so if we insert these packs, what happens is this is a sponge. Okay, this is a sponge. It's hydroxylated. It's a sponge. So what will happen is the moment blood comes in contact, because the person will have epistaxis. So whenever the blood or any mucus will come in contact with this sponge will become double in size. Okay, they will expand like a foam and they will become double in size. And that will give pressure tamponade to the vessels of the nasal cavity. And that will stop bleeding. So this is very useful for anterior nasal packing nowadays. And it is called as merocell packs. Remember this. Okay, remember this, right? Okay, now, a patient has been constantly having sneezing and rhinorrhea as well as itching as well as nasal block. The patient comes to you and this is the face of the patient. Now, can you tell me what is the diagnosis of this patient? The patient has 4 symptoms: rhinorrhea, itching, block and sneezing. Rhinorrhea, we can call it as ribs, itching, nasal block and sneezing. Can you just see this face and identify what is the problem with this patient? Okay, so this is called as an allergic face. This is called as allergic facies. So this is an allergic face. Okay, and here only there are important questions. Any allergic person will do what? The moment any person has allergy, they'll do this, right? This thing is called as an allergic salute. And when we call a salute, they will cause this kind of a line over them. This is allergic rhinitis, correct? This is allergic rhinitis. So, allergic rhinitis will have this line because of the allergic salute. They will have a line over here, and this line is called as a dorsal nasal pleat, and it is the other name is called as Darier's line. It is also called as Darier's line, also called as a dorsal nasal pleat because of the constant salute that these people give. Also, if you see, this person has got big dark circles, and these are called as allergic shiners. These are called as allergic shiners. Okay, so why do people with allergies have got dark circles? The reason is that, see, always remember, dark circles are not hyperpigmentation. Dark circles are veins which are showing off. They are venous congestions which are showing off. That is why we say that have a beauty sleep. Why? Because the face becomes relaxed. So our facial veins are valveless. They do not have valves, right? So whenever we move our face veins get congested. Whenever we relax, they drain away into the internal jugular vein. So that is why we say facial massage and relaxation for taking out the dark circles. So allergy people usually keep using their, whole face a lot. Why? Because they are allergic, right? And because of this allergy, they don't sleep well and they develop these dark circles and the veins are congested and they show up as shiners, which are called as allergic shiners. So there is Darier's line. Another important line is present underneath their eye. You can see a faint line underneath their eye. This is because of the eyelid muscle spasm. Okay, because again and again allergic people will keep doing this also because eyes are also allergic, right? They will water. So because of the excessive compression over the eyelids, the eyelid muscles undergo spasm and they create a line in the infraorbital area, and this is called as Denny-Morgan crease. This is called as Denny-Morgan crease. So Denny-Morgan crease or Denny-Morgan fold, also called as infraorbital fold, these are all signs for allergic rhinitis. Okay, remember this. Right? Okay. So have you got it? Right? So this is about what you need to know in allergic rhinitis. One more question is that if I do an endoscopy of this particular patient, an endoscopic image of this patient, I don't have it unfortunately, what will you see? Endoscopic image of allergic rhinitis will show mulberry turbinates. Will show mulberry turbinates. Mulberry matlab that they will be, like this. The turbinate will be like this. So they're like a mulberry. Okay, so this is called as a mulberry turbinate sign, which is also seen in allergic rhinitis. That's all. Okay, that's all what you need to know as far as allergic rhinitis is concerned. Okay, now let me go on to another domain. Lot of domains are there in ENT. Let us go on to the other side. 7-year-old boy came to you with symptoms of excessive respiratory obstruction. The patient is not able to breathe and there is a huge swelling that is present over at the lower end of the mandible. This patient had a history of tooth extraction 5 days back. What is this particular diagnosis? History of tooth extraction, swelling present in the submandibular and sublingual area, and the patient is hardly able to breathe. What is this diagnosis of this patient? Just by seeing this face, you should diagnose. Yes, very right, Sanskar. This is Ludwig's angina. Ludwig's angina. So Ludwig's was the first one who notices angina means severe pain. So if the person, whenever you see these cases where there is excessive, edema as well as swelling over in the submandibular as well as sublingual area, it has swollen up like this, right? This answer would be Ludwig's angina. Okay, so they basically cause excessive swelling in the submandibular and sublingual space. Sublingual space. Now, is Ludwig's angina a pus-forming abscess? No. It is not an abscess. It is a polymicrobial cellulitis. It is a polymicrobial cellulitis. Cellulitis means that the soft tissues, the subcutaneous tissues, they are getting, edematous. They are the ones which are enlarging. So it is not pus forming. Like retropharyngeal pus has pus, parapharyngeal abscess has pus. Ludwig's angina doesn't have pus. Okay, so it is just cellulitis. Remember that, of the subcutaneous tissues. Now, when there will be so much of edema over in the submandibular and sublingual spaces, what will happen? there will be significant edema in the floor of mouth. Significant edema of floor of mouth. Right? And the floor of mouth, if there is significant edema, they are going to raise the tongue. They're going to raise the tongue. And that is the reason, because the tongue is raised, they will have respiratory obstruction. And that is why these particular children will come to the emergency straight away. Okay? So that is what you need to know as far as Ludwig's angina is concerned. Now, how will we treat it? Obviously, medical line of treatment is the first one. We have to start on high-grade antibiotics. But at the same time, we need to relieve this pressure. Right? So what do we give? We give an incision from one angle of mandible to another angle of mandible. Straight away. Now, this is a very bad incision. It looks like a suicidal incision. But actually, it is a life-saving incision from one angle of mandible to another angle of mandible. Cut it. As soon as you'll cut open the subcutaneous tissue, the edema of this compartment will get released. And then we put drains. We put drains over here so that the edema should be relieved. Nowadays, instead of putting these big incisions, we have started putting one incision in one submandibular fossa, another incision in another submandibular fossa, so that we can keep two drains on both the sides. Right? So that looks a little more cosmetic, but anyways, this is something which is more of an emergency condition. Okay? If we have got respiratory obstruction as well as the child is desaturating, then we have to do a tracheostomy as well. Because you can't intubate the patient here. You can't put an endotracheal tube, there's hardly any space. So we have to do tracheostomy also. Okay, fine. So this is about what you need to know as far as Ludwig's angina is concerned. Remember, it's a polymicrobial cellulitis. One more question. What is the most common cause of Ludwig's angina? Tooth infection. Most common cause of Ludwig's angina is tooth infection or any tooth-related extraction. That is why when they give you histories also, they will usually give this important clue that this patient underwent the tooth extraction. Right? So that would be the clue that this is Ludwig's angina. Okay, fine. Chalo. Now let me show you one more. A patient came to you and this patient had a history of fish bone ingestion. Okay. Now he neglected that fish bone ingestion. That fish bone also he told that it went away. He swallowed it. It was no problem. After 3 days, this particular person came to you. You opened the mouth and you see this kind of a picture inside the mouth. What is the primary diagnosis of this patient? Now think and tell me what has happened to this patient. Okay. So you have opened the mouth of this patient and you can see something which is wrong in this oropharyngeal area. Now think what is wrong in here. Okay, what has gone wrong to this particular person? Yes, this is quinsy. This is quinsy, very right. So quinsy, the other name is peritonsillar abscess. Peritonsillar abscess. Okay, now this is a very important thing that you need to understand. This is your tonsil. Okay, the largest crypt of the tonsil is called as crypta magna. This is called as crypta magna. Largest crypt of the tonsil. Now here I want to tell you something about tonsillar bed. Okay, so the tonsil has got a covering right on the lateral surface and this is called as a tonsil capsule. Okay, this is a fibrous connective tissue condensation of the tonsil. It forms a capsule on the lateral surface. Lateral to the capsule, there is an area which has got loose areolar tissue. Loose areolar tissue. Okay. Posterior to the loose areolar tissue, you have got another area, another important covering, and this fascia is called as pharyngobasilar fascia. Basilar fascia. Behind the pharyngobasilar fascia, you have got another important muscle, and this muscle is called as superior constrictor muscle. Behind the superior constrictor muscle, there is another important fascia which is called as buccopharyngeal fascia. Buccopharyngeal fascia. So what are the things inside to outside? Capsule, then comes the pharyngobasilar loose areolar tissue, then comes the pharyngobasilar fascia, then comes the superior constrictor muscle, and then comes the buccopharyngeal fascia. Now what happened to this guy? When he ate that fish, it got some injury over on the tonsil. Okay? Now that injury that was created, let those organisms go inside the tonsil through the crypta magna, and now they started to form pus between this superior constrictor muscle as well as the capsule. So the space present between the superior constrictor and the capsule is called as peritonsillar space. What is peritonsillar space? It is present between the superior constrictor as well as the capsule. If there is pus formation in this layer, we will call it as peritonsillar abscess, or we will call it as quinsy in simple terms, right? Okay, now, when a person will have quinsy, right, what will happen? You will see that there will be unilateral enlargement of the tonsil. The tonsil will become red and erythematous. There will be unilateral involvement. The uvula will get deviated towards the opposite side, correct? And at the same time, what you will see is that this particular tonsil or tonsillar area will have got a lot of pus which is extruding out. So they will have a lot of pus which is extruding out. So uvular deviation to the opposite side, there will be unilateral erythema and edema of the tonsil, and the uvula, as well as there will be pus which is extruded out from this tonsillar substance through the crypta magna. These are the signs that the person has peritonsillar abscess. Okay. Now, how will we treat it? Incision is the way to treat it. We have to incision and drainage. How will we put incision and drainage? If we draw one imaginary line along the base of the uvula, one along the base of uvula, and one line along the anterior pillar, one line along the anterior pillar, one line along the base of uvula, the intersection point is the one which has got the maximum fluctuation. And this is the point where we'll put that incision and drain. This is called as quinsy drainage. So one line along the base of uvula, one line along the anterior pillar, at the intersection we drain. That is what is all important for quinsy drainage. Okay, fine. So this is what you need to remember as far as quinsy is concerned. Okay? Chalo. Now let's come to the next one. Identify this particular instrument. What is this instrument? And what is the full name for this instrument and why it is utilized? Okay, so the name of this instrument is what? This is called as St. Clair Thompson adenoid curette. Adenoid curette. Okay, this is called as St. Clair Thompson adenoid curette. Okay, very important question that has come, right? So how do we do curettage? We hold it like a dagger, like a dagger. We hold it like a dagger. We put it inside the oral cavity. We go behind, right? And we move it with the wrist, like a wrist motion. We are curetting out the adenoid. So we move out in the form of a wrist action. Like, see, we engage it and we scoop it out. And that is why it is called as curettage. One important question that these people have asked you a lot is that during curettage, what is one complication that can happen to a patient? So during curettage, we need to be very careful. That's why during the adenoid curettage, we always flex the patient's neck. And why do we flex the patient's neck during curettage? It's because it can put pressure at the atlanto-occipital joint and that can get dislocated. And that is called as Grissel syndrome. What is Grissel syndrome? Grissel syndrome is atlanto-occipital dislocation. Sorry, atlanto-axial dislocation. Atlanto-axial dislocation, like the atlas and axis, right? So that gets dislocated, right? There is a ligament which holds them, that's called as transverse ligament, and it gets dislocated, it gets injured, and that is what produces this syndrome that's called as Grissel syndrome. That is why one important thing we do during adenoidectomy is flex the patient's neck. That is an important thing. Okay, fine. Now, let me come on to another important thing, that is the surface anatomy of nasopharynx. Very commonly asked question. ये आपको दिखाएंगे कि ये nasopharynx है. What they will tell you, what are the parts of the nasopharynx, and they will ask you what are the areas. This is the nasopharynx, right? What you are seeing right now. Okay. This is the posterior pharyngeal wall. This is the posterior wall, right? Posterior pharyngeal wall. Now, what is this slit-like opening that you are seeing on the lateral wall of the nasopharynx? This slit-like opening present in the lateral wall of the nasopharynx, this is called as a eustachian tube opening. Okay, this is a eustachian tube opening. This is whole is the nasopharynx, right? This is the nasopharynx. And this is your eustachian tube opening, the slit-like opening. Okay. Above the eustachian tube, this area, what you can see as an expanded area, like a cup, which is above the eustachian tube, this is the cartilaginous end of the eustachian tube. And we call this as torus tubarius. We call this as torus tubarius. So torus tubarius is an elevation of the cartilaginous end of the eustachian tube, which is present above the eustachian tube orifice. Very important. ठीक? अब इसके पीछे देखो. Píche to the torus, just behind the torus where this arrow is. Can you see this space? A slit-like space. This space is fossa of Rosenmuller. तो क्वेश्चन क्या आएगा? They will ask this space only as the question. This is fossa. Now remember, torus के नीचे ET के पीछे fossa. So that is your fossa of Rosenmuller. What is the most common site for nasopharyngeal carcinoma to happen? Fossa of Rosenmuller. Okay, this is the site. Now, you see one fold coming from the torus tubaris here. This fold is called as salpingopharyngeal fold. Salpingopharyngeal fold. And another fold which is present behind this fold, this is called as salpingopalatine fold. Salpingopalatine fold. So one is a salpingopharyngeal fold, one is a salpingopalatine fold. उसके बीच में ET orifice, उसके ऊपर torus, पीछे fossa of Rosenmuller. These are the important things you need to remember as far as topography or surface anatomy of nasopharynx is concerned. ठीक है, यही questions बनते हैं. Okay? चलो. Now, what is this position? ये भी बहुत common question है. What is this position और ये किस में दी जाती है? Okay? So the name of this position is just like a boy giving a rose to a girl. And how does a boy give a rose to a girl? They sit down, right? And they extend their head completely. And they give it like this. So what is it called as? It's called as rose position. So this is called as rose position, which has both extensions. The extension at the atlanto-occipital joint as well as the cervicothoracic joint. So the neck and the chest are also extending. The cervicothoracic joint is extended as well as the atlanto-occipital joint is extended. Both joints are extended. We will call it as rose position. Rose position is commonly used in which surgery? Also a question. Rose position is used in tonsillectomy, adenoidectomy, and tracheostomy. Most common surgeries where we require this position. Okay, right? These are the important ones which we utilize rose position. Right? अब इसी के साथ एक और position है that you should also remember. ये कौन सी position है? This is called as Boyce position. Boyce, B-O-Y-C-E. Boyce position. Now, what is the difference between Boyce position and rose position? Rose में दोनों joint extended थे. Boyce position में we will not put a shoulder, pillows to extend the head. What will we do is, we will raise the head end of the patient by 10 to 15 centimeters. So if we raise the head end of the patient by 10 to 15 centimeters, what will happen? There will be extension at atlanto-occipital joint. And there will be a flexion between cervicothoracic. So the neck and the chest will become flexed as well as there will be extension at the atlanto-occipital joint. This is called as Boyce position. उसमें दोनों joints extended हैं. Cervicothoracic भी as well as atlanto-axial भी और atlanto-occipital भी. This is important. दोनों joint extended हैं. Rose. एक joint पे extension है, एक पे flexion है. That is Boyce. Now Boyce is given in what? Boyce is done by what? Boyce means all scopies. Whatever you remember, सारे scopies. Laryngoscopy, esophagoscopy, bronchoscopy, सारी स्कोपी हम Boyce position में करते हैं. Okay, remember this. The other name for Boyce position is also called as sniffing the morning air position. हम ऐसे sniff करते हैं ना, right? That is called as sniffing the morning air position. It is also called as barking dog position. Barking dog, right? If you see a dog barking, it will put his head in front, right? And then the dog will bark. That is also called as barking dog position. It is also called as sword swallowing position. जैसे हम swallow करते हैं किसी sword को. तो बहुत सारे नाम है. But it also means the same thing. All mean the same thing. Okay? Fine? Chalo. Okay. Now, you have got a patient. Patient has been having severe fever and there is extreme enlargement of the neck, which the patient has noted, and also there is intense throat pain. You open the mouth of the patient and you see a grayish membrane over the left tonsillar area. Now, when you take this membrane out, this membrane starts to bleed. What is the diagnosis? Correct. So, Jitu is correct. This is faucial diphtheria. Faucial diphtheria. Okay? And these people will have a pseudomembrane. They will have a grayish white membrane, dirty membrane. As soon as you will remove the membrane, they will start bleeding. The classical presentation of diphtheria is a bull neck deformity. Bull neck. Bull neck means what? There will be lymph nodes of the neck which will get swollen and they will become like a bull. So that's called as bull neck deformity. Membrane which is dirty white. Remember, diphtheria happens because of Corynebacterium diphtheria. Okay? Chalo. Now, what are these instruments? Explain these instruments. What are these instruments? So this is what these are instruments which we usually require in tonsillectomy and adenoidectomy, right? And this arrangement, this is called as a Boyle-Davis mouth gag. This is called as Boyle-Davis mouth gag. Okay, so B for Boyle, B for blade. Boyle was the one who gave the blade, and Davis was the one who gave the gag. So together with that, it's called as Boyle-Davis mouth gag. Very rightly said, Rishika. This is the Draffin's bipod. This is called as Draffin's bipod, and it attaches to a plate below. Can you see this plate? This plate is called as Mc-Goran's plate. Okay. So Mc-Goran, not McDonald. This is Mc-Goran, right? This is Mc-Goran's plate. And all of this assembly together is utilized in very commonly in tonsillectomy and adenoidectomy, जिसमें हम लोग कुछ इस तरीके से patient पे पूरी assembly लगाते हैं, right? So that the patient can be, we can visualize the whole oropharyngeal area, right? This is what you should know. And this is a tonsillectomy being done. So what is this position? This is Rose position, what we have already discussed. Okay, fine. Okay, now, how do we hold the tonsil? We hold the tonsil by this instrument. Okay. Now, what is this instrument? This instrument is for holding, not biting. Okay. So, this instrument is called as Dennis Brown tonsil holding forceps. Holding forceps. Okay. इसमें ये ring होती हैं. These are the rings. This is the shaft or shank of the instrument. And always remember, they have got a joint which is a box joint. This is a box joint. Okay. And these are the ones which hold the tonsil. The ends of the one are holding the tonsil, right? Okay. Not the Quincy forceps. Quincy forceps dagger like होती है. उसमें dagger की तरह होता है. Quincy forceps में इस तरीके के dagger होते हैं. Okay. So this is not a Quincy forceps. This is the one which is for tonsil holding. And that is why it is used in tonsillectomy. So this is a Dennis Brown tonsil holding forceps. Okay. ये चीज क्या है? What is this? Very important instrument that they ask in exams. Okay. This is a snare which we use in snaring, and this is usually used in the last step of tonsillectomy. क्योंकि last step of tonsillectomy में हम cut नहीं कर सकते tonsil. Why? Because the tonsil के lower pole पे, the lower pole has got an artery which is called as tonsillar artery, which is a branch of facial artery. So the lower pole of the tonsil is always snared, and this is called as Eve tonsil snare. Eve tonsil snare. Okay. So this is utilized at the lower pole of tonsil to crush the tonsillar branch of the facial artery. Okay. It's not cut, it's snared. And this is a wire loop. जिसके बीच में we will put that tonsil and we'll crush it. Okay. Fine. This is also a very important instrument. You should just identify them. Okay. Now let's go on to the final segment that are quickly, let's complete what are the ear images that are shown. Okay. Fine. Now, what is this? Okay, a patient came to you, he had a history of trauma, and after trauma, this particular patient developed some kind of a swelling over the pinna area. Okay, some kind of swelling over the pinna area. Right? Now, what is this particular thing? Right? So, this is called as perichondritis. Boxer ear जैसा ही दिखता है, पर boxer ear में क्या होगा ना? It will be red and it will be inflamed in one area. इस तरीके का red होगा. But this is completely inflamed. So this, when it has complete inflammation, history of trauma, अगर localized trauma होगा और यहीं पे there is something which is elevated, that is hematoma oris, what you told as boxer ear. But if it is completely swollen, we will call it as perichondritis. Perichondritis. Right? The only thing that you need to see in perichondritis is that in perichondritis, there will be complete inflammation of the pinna. Lobule will be spared. Lobule is spared. Why? Because lobule doesn't have cartilage, doesn't have perichondrium. Okay? Now, this pinna will become red, it will become boggy, and at the same time, the moment you will push the pinna, it will have a lot of pain. So this pushing of the pinna is called as circumduction test. When you move the pinna, it's called as circumduction test. It'll pain a lot. The most common cause of perichondritis is trauma. So it mostly happens because of piercings or piercing trauma. Most common organism for perichondritis is Pseudomonas. Most common drug utilized for perichondritis is ciprofloxacin. सारे question. Ciprofloxacin loves Pseudomonas. So जहां पे Pseudomonas होगा, drug of choice ciprofloxacin ही होगा. Remember that. Okay. Now, why is ciprofloxacin given in Pseudomonas? Because it is the most potent anti-pseudomonal drug, and at the same time, it is a cartilage penetrating drug. It will penetrate the cartilage and it will cause, healing. Okay. So this is a very important question. All of them are questions that you should remember. ठीक है? चलो. Next question पे आते हैं. This is a patient who is a 4-year-old boy, and the mother noticed some fluid coming out from an opening present at the anterior end of the pinna. What is this diagnosis? Okay, what is the diagnosis here? Okay, so there is fluid that is coming out from this opening again and again. And this fluid keeps coming out, and then it stops, and then it again comes out, then it again stops. Okay, yes, this is a pre-auricular sinus. In front of the ear, if there is a hole, it has to be pre-auricular sinus. Okay, so sinus means a blind track. So ये track बन जाता है, and that is called as a pre-auricular sinus, right? Now, why does a pre-auricular sinus happen? Because of the malfusion or an incomplete fusion between the first and the second tubercle of his, right? Pinna develops from certain swellings. So at sixth week of gestation, the pinna develops from 6 tubercles of his. Okay, 6 tubercles, 6 week, और pinna भी 6 की तरह दिखता है. So that is why 6 develops at 6 weeks from 6 tubercles of his. If there is malfusion between the first and the second tubercle, first tubercle forms the tragus. First tubercle will form the tragus, which is here, this projection. And the second tubercle will start forming the helix. So if there is malfusion between the first and the second tubercle, it will leave an opening over here, and that is called as preauricular sinus. Okay? Treatment for preauricular sinus, excision. We excise the preauricular sinus. That's all. That's all that you need to remember. Okay? Okay, now, 2 important diagnoses just by seeing. So one appears to be something abnormal here. It looks like abnormally large ear. And one is gone down. One is like this. What are these diagnoses? Just by seeing, you need to tell me what are the diagnoses. If this particular condition happens, you can see here, this inside one is the antihelix. The outer one is called as helix. This is the helix. The inner one is called as antihelix. Here, in this condition, the antihelix is poorly formed. You can see that? Antihelix is poorly formed. You can see that here, right? You can even see the concha is abnormally large, a big concha. Antihelix is poorly formed. And this fossa, which is present over here, just put your finger over here in the end of your helix. This fossa is called as scaphoid fossa. This fossa here is called as scaphoid fossa. And in this patient, scaphoid fossa is poorly formed. Poorly formed. So 3 things: antihelix not well formed, scaphoid fossa poorly formed, big concha. What is the answer? Bat ear. Correct. So this is a bat ear deformity. This is a bat ear deformity. Okay, fine. Now, let's say this patient, okay, this is upper 1/3 of the pinna has dropped down, curled. What is this deformity? If the upper 1/3 of the pinna drops down or it becomes curled, it is called as lop ear. This is also called as lop ear. Okay, so remember, this is lop ear, this is called as bat ear, right? Chalo. Now, a person has come to you, the person is diabetic, and the person has got ear discharge and severe pain inside the ear. Severe pain inside the ear and ear discharge. And the patient is diabetic. You go inside the ear, and inside the external auditory canal, you see something like this. What is the diagnosis of this patient? Just by seeing, you see something black, something white. What is the diagnosis of this patient? Diabetic person. This is a clue. Diabetic person. That means he's immunocompromised. And you see something black, something white over in the external auditory canal. Severe pain as well as some kind of discharge that is coming out from the ear. So what can you think of here? So this is otomycosis. This is otomycosis. See, I told you, fungus loves diabetic people. Fungus loves immunosuppression. So ear also has got certain things, right? So now, two most important organisms to cause otomycosis: Aspergillus niger, and Candida albicans. Two most important ones, right? If Aspergillus is present, they will have black filamentous heads. You will see black filamentous heads or hyphae. You will see these black filamentous hyphae. If Candida is there, you will see curdy white colonies. You'll see curdy white colonies and they will have black filamentous heads, right? That is what is called as wet newspaper appearance, black and white, right? So very, very good. That's what is wet newspaper. Now see, this looks like a wet newspaper. You can see these filamentous heads coming out, black, black, black. These are all the heads for Aspergillus niger, right? And if it would have been Candida, then it would have been all white. It would have been a white, curdy white. It would have been like this. It would have been curdy white. And that curdy white is just because of Candida albicans, because it's white. Alba means white. Okay, so this is called as wet newspaper appearance. This is called as wet newspaper appearance. Okay. So remember this line. Okay, this is otomycosis. Okay. Now, what is the drug of choice? So usually what do? We take them out. We suction the ear, right? We take out all the fungal debris. That's called as oral toileting. And at the same time, we give them local drops. And these drops are nystatin, and clotrimazole. These are the true drops what we can give. Either give clotrimazole or give nystatin. Okay, that is a line of treatment. And we tell them not to keep the ear moist. Okay, so avoid water entry inside the ear. That is what we'll always tell them. Okay, chalo. Now let's come to this. Okay, ab ye kya hai? What do you see here? This is a normal tympanic membrane. पर normal tympanic membrane में भी हमें पता होना चाहिए क्या structure होते हैं. This is what they will ask you. Okay, so I always tell how to remember this is right side or left side. अगर tympanic membrane right की तरफ tilted है, it is right. अगर ये left की तरफ tilted है, तो left. तो अगर right की तरफ tilted है tympanic membrane, then it is right. अगर left की तरफ tilted है tympanic membrane, then it is left. Simple. So अगर obviously this is tilted towards the right side, so obviously this is the right side tympanic membrane. Okay, now if I draw an imaginary line, one along the handle of malleus and one crossing this umbo, this point where the handle of malleus, this is the handle of malleus. So this handle of malleus is attaching to the pars tensa, and the point where it attaches is called as umbo. It's called as umbo, right? So one line along the handle of malleus, one line crossing the umbo. I can divide my tympanic membrane into 4 parts, right? I can divide my tympanic membrane into 4 quadrants. One is called as antero-superior quadrant, one is antero-inferior quadrant. Okay, just let me put this line a little more superior. Okay, one is called as posterior-inferior and one is called as posterior-superior quadrant. These are the 4 quadrants of the tympanic membrane, correct? There are 2 parts of the tympanic membrane. One is pink in color and it is above, that is called as pars flaccida. One is grayish white and shining, and this is called as pars tensa. Around the pars tensa, there is a fibrous ring. And this fibrous ring, what is shining around the pars tensa, this is called as annulus. This is called as annulus. In the antero-inferior quadrant, you will have a reflection of the light what you are throwing through an otoscope, and this is called as cone of light. So cone of light is present in antero-inferior quadrant. Why? Because of the reflection of what your otoscope or your light is giving. Okay. Now, in the posterior-superior quadrant, you can't see it very well here, but there is a reflection that we get of 𝐒𝐄𝐝 joint. Okay. So reflection of 𝐒𝐄𝐝 joint is seen in cases of posterior-superior quadrant. That is why posterior-superior quadrant disease is the most unsafe disease of the pars tensa. अगर यहाँ पे कोई disease है, we'll call it unsafe here. Why? Because the 𝐒𝐒𝐝 joint is present in the posterior-superior quadrant. Very, very important question. The posterior-superior quadrant में 𝐒𝐒𝐝 joint होता है, and that is the reason why you have got the most unsafe diseases there. क्योंकि अगर ये चला गया, there will be conductive hearing loss. Okay? Fine. This also we have understood. Now, you have got one projection here from the malleus, right? Which is projecting out here, what I'm showing you here. This is the lateral process of malleus, what you can see. This is the lateral process of malleus. Okay? These are some things that you should know about the normal architecture of the tympanic membrane. Okay? Now let me go into specific things. ये आ गया. Now just think of what am I talking about. This is a condition which happens bilaterally in females of the reproductive age group. यानी एक female आई of the reproductive age group with bilateral progressive hearing loss. Now this patient tells that the mother had this particular problem of hearing loss at the time of her first childbirth. And she also had the same problem at the time of childbirth when she gave birth to her child. That means during pregnancy, this particular condition worsened. You did an examination of the tympanic membrane and you found something at this area. Now you have to tell me what is the diagnosis. Yes, Gayatri has already told it right. It is otosclerosis. Whenever you get this scenario, bilateral progressive hearing loss, female reproductive age group, hereditary and hormonally influenced. Hormonal means what? That it happens during pregnancy, puberty or menopause. Always remember, it has to be otosclerosis. Okay. Now, otosclerosis is what? Otosclerosis will have what? They have got otosclerotic lesions, right? Right? So, it is a problem which happens in the enchondral bone of the bony labyrinth. Bony labyrinth has got 3 layers, periosteal layer, endosteal layer and the endochondral layer. The enchondral layer is the one which is causing otosclerosis to happen. Now, what will happen if these otosclerotic foci will be active? Active मतलब ये vascular होते हैं and later on ये sclerotic हो जाते हैं. So in the earlier stages of otosclerosis, these foci are very active. And that is why they will shine through in the posterior-superior quadrant. I told you that posterior-superior quadrant has 𝐒𝐄𝐝 joint. And 𝐒𝐄𝐝 joint has got stapes. So obviously, they will shine through the posterior-superior quadrant. So in active otosclerosis, active, ये याद रखना, active otosclerosis, you will have Schwartz sign, also called as flamingo-pink sign. Okay, flamingo-pink sign or Schwartz sign. These otosclerotic foci which are active, right? Which are very, very vascular. They will shine through in the posterior-superior quadrant. That is called as Schwartz sign or flamingo-pink sign. 3 in cases of active otosclerosis. ठीक है, अब ये याद रहेगा. This is a very, very important sign for you to decide. अब एक चीज यहाँ पे एक important चीज आती है. 2 तरीके की otosclerosis होती हैं, active and inactive. Inactive मतलब the bone is completely sclerosed. Active मतलब they are still proliferating. Right? So in the active stages of otosclerosis, we give medical line of management. Inactive में we do stapes surgery, which is called as stepidotomy. So active stages of otosclerosis, when Schwartz sign is positive, what will be the line of action? Medical line of management. And the drug of choice here is sodium fluoride. So sodium fluoride is only indicated to be given in active stages of otosclerosis. But what happens in inactive stages when the otosclerotic foci has formed? It has become chalky white. It has fixed the stapes. In inactive stages, we do stepidotomy. Stepidotomy. Okay, okay. So these are the things that you should remember. Okay, in cases of otosclerosis and the questions that they will ask you. Theek. Now, let's come to this. A patient has come to you with conductive hearing loss and pulsatile tinnitus. On examination, you see this kind of an image on otoscopy. What is the probable diagnosis of this patient? इसमें क्या बनेगा? What is the probable diagnosis of this patient? Okay, you see something like this, something here, reddish here, right? Conductive hearing loss, pulsatile tinnitus. This is what I have told you. Conductive hearing loss plus pulsatile tinnitus. Okay, what can happen to this patient and what is the sign called as? Okay, yes, this is glomus tympanicum. Glomus tympanicum. Okay, the middle ear, right? So glomus tympanicum. Tympanum means middle ear. So this is glomus tumor. We'll call it as glomus tympanicum. Okay, now this sign is called as rising sun sign. Rising sun sign. The rising sun sign is a reddish mass because it's very vascular and it is seen in the middle ear. It's shining through the middle ear and it looks like a rising sun. And this is called as a rising sun sign. Now here only I'll tell you important signs of glomus tumor. If you have got a glomus tumor which is seen through a normal tympanic membrane, we'll call it as a rising sun sign. That is the first sign. Second sign of glomus tumor is called as brown sign. It is called as brown sign. What is brown sign? If I do pneumatic otoscopy means if I put pressure inside with a Siegel speculum, this tumor will blanch. B for brown, B for blanching. So if the tumor blanches on giving pneumatic otoscopy, or pneumatic otoscopy matlab using a Siegel speculum, when I put pressure, it blanches, that's called as brown sign. Third is aquino sign. If the tumor blanches on putting pressure over the carotid artery, because it is a carotid artery dependent tumor, the branches of carotid artery are going in it. If I put pressure on the carotid artery and the tumor blanches, it's called as aquino sign. So blanching on pressure on carotid artery, that is aquino sign. 3 signs you should remember. There's also something called as Phelps sign, which is seen on CT, which is the erosion of keratojugular spine. That I have discussed in my radiological segment. So you can go and check out that, right? That what is Phelps sign. But remember, clinically, there are 3 signs. What you should remember. Okay? Chalo. Now let's quickly go into another one. A patient had a road traffic accident. And this particular patient developed a bluish ecchymotic patch present in the post-auricular area. Now what is this sign called as? This is usually a sign which is seen in temporal bone fractures or basilar skull fractures, which is an ecchymosis in the post-auricular area. Yes, this is called as battle sign. This is called as battle sign. Okay, so remember, this is ecchymosis. Okay. Tinnitus disappearing on carotid compression. Yes, tinnitus also disappears, but that aquino sign is basically the blanch. It's basically the blanch. We can see that because it is supplied by the carotid artery. So you could visibly watch it. Tinnitus also will subside when we put pressure over the carotid artery. Okay, Rishika? Okay. So this is called as battle sign, right? Battle sign is post-auricular ecchymosis. Okay, remember that. Chalo. Now, let's come to the other one. You have got a child who has got adenoid hypertrophy. When the child has adenoid hypertrophy, that child had got conductive hearing loss. When you looked into the child's ear, you got something like this. There is some kind of an appearance which is present like this. What is this appearance of the tympanic membrane and what is the diagnosis? Yes, very rightly said by Gayatri. You can see multiple bubbles that are present of fluid or air fluid levels which are present in the middle ear. That has happened because of the eustachian tube obstruction because of that adenoid hypertrophy. And these are signs for serous otitis media. Okay, it's also called as non-suppurative otitis media. It's also called as glue ear. It's also called as serous otitis media, right? So you have different names, or otitis media with effusion. All these names are the same. So you have got this bubble appearance whenever there is serous otitis media with conductive hearing loss. अब इसी से related एक question है that what is this instrument what we utilize in doing surgery for otitis media with effusion? Okay, what is this instrument? If you see, this is a dagger-like instrument. It has got a dagger-like end. इसके dagger की तरह एक end है. So what is this instrument and what is the surgery that we do in cases of OME? Yes, this is a myringotome. This is called as myringotome and we do the surgery called as myringotomy. Myringotomy. Okay, so we create an opening and usually this opening is created with a radial incision. हम एक incision देते हैं, like a straight incision. So let's say this is a tympanic membrane, right? We give a straight incision. This is called as radial incision. Okay. Now, if there is too much of pus, then we can even give another incision in the anterosuperior quadrant, and that is called as beer can principle. If we give too two incisions, one in the anteroinferior, one in the anterosuperior. That is called as beer can principle, which we utilize in cases of acute suppurative otitis media because there is so much of pus. But if we give a single incision, which is called as a radial incision, from the umbo till the annulus, that is the one which we utilize normally in the anteroinferior quadrant in cases of OME. After that, we insert something. So what is this called as? We insert a tube inside, and this tube is going to maintain the ventilation of the middle ear. And what is this tube called as? This tube is called as ventilation tube. Ventilation tube. Or it is also called as grommet. Grommet or grommet. Okay, so this is something that is come for identification, that grommet is inserted. It's a ventilation tube for maintaining the ventilation. This is self-extruding. ये अपने आप निकल जाएगा after 2 to 3 months. You don't need to care about it because the tympanic membrane will grow and slowly it will push out the grommet out towards the external auditory canal. Okay, so this is what is done in OME cases. That is what you need to remember. Chalo, let's come to the next one. This OME was left untreated. अब इसको हमने छोड़ दिया. It was left untreated. And what happened was, after 7 days, this child came up with severe ear pain and fever. And we saw this type of a tympanic membrane. Now, what is this sign on the tympanic membrane and what is this? Now, what has happened to the child? In untreated OME cases, what has happened to the child now? What is this? Yes, very good. This is cartwheel appearance. Now, the organism started to go inside that middle ear fluid, and that non-suppurative otitis media became suppurative otitis media. Correct? All of you are correct. So now in suppurative otitis media, what are the signs, right? So there are stages of ASOM or acute suppurative otitis media, right? The first stage of ASOM is called as stage of tubal occlusion, which leads to closure of the eustachian tube opening because of edema. The second stage is called as stage of pre-suppuration, or also called as stage of congestion, where we see leash of blood vessels. You can see leash of blood vessels congested over the tympanic membrane. Many blood vessels congested over the tympanic membrane. This is a stage of congestion or stage of pre-suppuration, before the pus formation. And this is called as cartwheel sign. Cartwheel sign or cartwheel appearance. Now what will happen? The pus will start to form and a lot of pus will form. And when the pus will form, they will lead to stage of suppuration. Next stage. And suppuration will lead to bulged out tympanic membrane. You can see completely bulged out tympanic membrane. The only place where this bulging will not be present will be in the center. And why is that? Because the malleus is attaching there in the fibrous layer at the umbo. So that is why this is the layer, this is the one which will be, pulled inwards, and all the other parts of the tympanic membrane will be projected outwards. So this is called as bulging of tympanic membrane, which is seen in stage of suppuration. Now, the moment this tympanic membrane will bulge out, right? At one point of time, it will actually become so much that it will start to protrude and it will produce a dimple out. That this is going to perforate. When it is almost about to get perforated, it will produce a kind of a nipple-like projection, and we call this as nipple sign. Nipple sign. Like a nipple-like projection that is its impending perforation. It's going to burst out and the pus will all come out. And after this, there is stage of resolution. When the tympanic membrane bursts out, obviously the pus is going to start draining. That's called as stage of resolution. Okay, fine. So these are the stages of ASOM, what we have read, and these are the important things that you should know. Okay, chalo. Now let's come to important, let's finish off the important audiometries or the important audiograms. Right, that is only the dimple sign. That one only, the dimple sign or the nipple sign is the same. It creates a dimple. Okay, that's it. Okay, Rishika? Fine. Now let's finish off the important clinical audiometries. Okay. I already told you that there was a patient who came up with short sign positive. You did an audiometry for that patient and you saw this kind of a scenario where the bone conduction is dipping at 2000 hertz and even the air conduction is dipping in the speech frequencies. You can see speech frequencies means 500 to 4000 hertz. These are the ones which are called as speech frequencies. So there is air conduction which has dipped down. Bone conduction is dipping at 2000 hertz. This is called as Carhart notch. Correct. Everyone is correct. This is called as Carhart notch. Carhart notch. Carhart notch is classically seen in otosclerosis. Now, why is Carhart notch bone conduction dip at 2000 hertz? Why it is dipping at 2000 hertz? Bone conduction, not air, bone. It's because the ossicular resonance frequencies are maximum at 2000 hertz. Ossicular resonance frequencies are maximum at 2000 hertz. If the stapes is fixed, then these frequencies which will be affected will be 2000 hertz. Because ossicle vibrate करेंगी तो resonance नहीं match up करेगी. The frequencies are not going to match up. The maximum vibration is happening at 2000 hertz, and that is why the bone conduction is coming down at 2000 hertz. Yes, correct. Okay, fine. Factory में काम करने वाला आदमी. Now there is a patient who is working in a factory for a very long time. You see air conduction and bone conduction has both dropping down together, and they have dropped down at 4000 hertz. So now, if air conduction and bone conduction both drop down together, that's called as sensory neural hearing loss. I always tell sensory मतलब साथ साथ. S for S. Air conduction भी गिर रहा है, bone conduction भी गिर रहा है, साथ साथ गिर रहे हैं, and they are at 4000 hertz. That means this is the type of sensory neural hearing loss, and this notch is called as boiler's notch. This is called as boiler notch. Or we also call it boiler maker notch. Boiler maker notch or boiler notch. Okay? So remember this is usually seen in noise-induced hearing loss. This is seen in noise-induced hearing loss. Okay? Chalo. Ab aate hain agle pe. Now I told you that this is also air conduction, bone conduction. Dono kaan ke bilateral. Left is blue, right is red. R for right, R for red. Left is blue. Both the air conduction, bone conduction are dropping down. And this is a sloping audiogram. Sloping. You can see a slope. So it is a sloping audiogram. Bilateral sloping audiogram. Where will you see this? Sloping audiogram is always seen in cases of presbyacusis. Presbyacusis. Okay, we can see sloping audiograms. Second, we can also see sloping audiograms in cases of ototoxicity. Okay, we can also see them in vestibular schwannoma. So sloping audiograms can be seen in vestibular schwannoma, ototoxicity, presbyacusis. Okay, very commonly. Okay, but remember that if they occur bilaterally, commonly, then they are usually presbyacusis, because presbyacusis is a bilateral disease. Okay, fine. Chalo. Now, what is this kind of audiogram? Here you see something strange. Here you don't see a fall in audiogram. Rather, the audiogram is rising. The audiogram is rising up. Right? You see rising type of audiogram. So this is also called as a rising curve. Rising curve. So here the air conduction and bone conduction are both rising up. So what is this? The rising curve audiogram is a class. जहां पे rise कर रहा हो ना, आँख बंद करके you have to answer Meniere's disease. Wherever you see rising audiograms, the answer is Meniere's disease. Okay. Now, why does this rising happen in Meniere's disease? This happens because of the phenomena of recruitment. This happens because of the phenomena of recruitment. Recruitment क्या होता है? In Meniere's disease, you get 4 important symptoms. What are they? VDTA. VDTA. Vertigo, deafness, tinnitus, and oral fullness. These are the 4 symptoms. Jahan pe bhi these 4 symptoms are told, it's Meniere's disease. Now this deafness is sensory neural type of deafness. Why? Because there is a loss of hair cells. हमारे जो hair cells होते हैं, they start getting damaged. Now when these hair cells start getting damaged, होता क्या है? That what happens in an army? When the first line of defense is lost, the second line of defense goes and it works the double in order to compensate the work of the first line. वैसे हमारे hair cell होते हैं. अगर first line of hair cell मर गए, so the remaining hair cells starts to double the function of what they lost. And now because of the doubling of these functions, what will happen is that they will suddenly start hearing a little louder and better. And that is why this curve also rises. And this is called as recruitment phenomena. They are recruits. उसे recruit कर लिया है, the remaining cells. अब कुछ time के बाद ये वाले cell भी काम करना बंद कर देंगे. So after some time, this whole, audiogram will become flat. And after years, they will completely die, सारे hair cell, and it will become sloping. So all 3 patterns of audiometry are seen in cases of Meniere's disease. In the earlier stage, it's rising. because of recruitment. Then it becomes a little flat, and finally it falls down when all the hair cells are dead. Are we understanding this concept? Right? This happens in recruitment, which is a phenomena seen in Meniere's disease. Okay? Chalo. Now we have done PTAs, important PTAs. Let's come into important impedance audiograms. ये भी बड़े important है, right? When I say impedance, impedance means resistance. अब resistance जब भी हम देखते हैं, whenever we are reading these impedance audiograms, we always plot a curve in relation to pressure and compliance. Compliance and pressure. Compliance का मतलब क्या होता है? Movement. Right? Movement of the tympanic membrane is called as compliance. अब let's say this is 0. This is the central pressure, 0. Let's make it 0. This side is positive. Let's say it is plus 200. This side is negative. Let's say it is minus 200. Okay? If we have a normal tympanic membrane, it will move well at a normal pressure. That is normal pressure and normal compliance. And we call this curve of normal pressure and normal compliance as A curve. A curve मतलब normal pressure, normal compliance. सब कुछ ठीक. अब आती है second type of curve. Let's say इस particular patient के otosclerosis हो गई. Let's say this patient had otosclerosis. So what will happen? There's nothing wrong with the pressure here. Only the tympanic membrane movement will be disturbed now. The compliance of the movement will become restricted. Why? क्योंकि stapes fixed है. There's fixation of the stapes. So what will happen? The compliance reduces, but the pressure is the same. And what is this called as? This is called as AS curve. अब इसका mnemonic क्या है? ASS for sclerosis. तो जहां पे भी AS है, write down otosclerosis and tympanosclerosis. Tympanosclerosis क्या होती है? Tympanosclerosis are chalky white deposits which happen in the tympanic membrane. And these chalky white deposits make the tympanic membrane very stiff. And that is the reason tonosclerosis presents with stiffening of the tympanic membrane and loss of compliance. तभी compliance गिर जाती है and we call it as AS curve. Okay, fine. Are we understanding now? अब आती है दूसरी चीज. एक चीज आती है जिसमें प्रेशर की प्रॉब्लम नहीं है, but the curve becomes too high. The compliance increases and this curve never closes. There's no problem with pressure, but the compliance is too much. As soon as sound goes, the compliance is too much. Too much. Why? Because the ossicles are not in continuity with each other. They are discontinued. तो इस कर्व को हम लोग कहते हैं AD. D for discontinuity. Mnemonic. Discontinuity. That means the ossicles are discontinued. Maybe the malleus and the incus are not connected. That is why the tympanic membrane is moving inwards too much. And this will never close because we can't assess how much it is moving. So that is called as AD curve. Very high compliance, normal pressure. Now let's come to another situation. Now there is a eustachian tube dysfunction. Matlab negative pressure has started to build up inside the ear. But still, the compliance of the tympanic membrane is okay. So if there is negative pressure but the compliance is okay, then the curve will shift towards the negative side, but still the compliance is as good as A. We will call this as C curve. C you can remember as E eustachian tube dysfunction. You can just write down E inside that C. So that is eustachian tube dysfunction, which causes negative pressure to build up. So अब आपसे question क्या पूछेंगे? That patient had adenoid hypertrophy. What curve will you see? So in the earlier stages of adenoid hypertrophy, there will be blockage of eustachian tube, and the curve that you will see is C-shaped curve. Why? Because there will be negative pressure in the middle ear. Right? Okay. Now what will happen? Next is flat curve. मतलब कुछ भी नहीं मिला. This is called as B curve. Flat curve. Flat मतलब कि no compliance, no pressure. Now when will a tympanogram become flat? दो चीजें याद रखो. Flat मतलब या तो it is fluid. Fluid means otitis media with effusion. और या फिर tympanic membrane फटा हुआ है. F for फटा हुआ है, F for flat. फटा हुआ है मतलब perforation. So either there is perforation or it is fluid. And obviously इसमें कोई compliance और pressure रहेगा ही नहीं. If fluid is there, हम कुछ नहीं कर सकते. The tympanic membrane will not move. Perforation है, we cannot assess the pressure, we cannot assess the compliance. These are the various tympanometries that you should remember. बहुत बार questions आते हैं, and these are the ones which will be asked you in your exams. Okay? चलो. अब end की तरफ चलते हैं. Right? Lot of things. ये क्या है? This is a baby who had a history of acute suppurative otitis media. After 2 days, you notice that there is a swelling in the mastoid area. What is this swelling all about? Okay, to diagnose this swelling, you can see a red erythematous swelling in mastoid. Correct? So this is ironed out appearance. This is mastoiditis. So this is called as ironed out appearance. Iron मतलब hot iron होता है ना, बिल्कुल वैसा देखेगा, गरम iron. That will be the one. This is called as ironed out appearance. Now, whenever a patient will have mastoiditis or inflammation of the mastoid, ये ironed out appearance जब होगी, it will become very big, right? So it will push the pinna forward. So there will be forward displacement of pinna. Okay. There will be obliteration. You can see here of retroauricular groove. This groove present behind the pinna. This is called as what? This is called as retroauricular groove or postauricular sulcus. So iska obliteration ho jayega. Why? Because there is so much of swelling here. Correct? Ironed out appearance, obliteration of retroauricular groove, forward displacement of the pinna, as well as red erythematous ironed out appearance. These are the signs of mastoiditis. At the same time, if you see inside the ear canal, this pus will come out in pulsatile manner. ये बिल्कुल pulsatile तरीके से pus आएगा. And that pulsatile otoria that will come out will look like a lighthouse shining a light. Lighthouse में ऐसे light आती है ना, light आई, light गई, light गई, light आई, ऐसी आती है ना. So you'll see pus coming out, going in, coming out, going in, like a pulsatile fashion, and that is called as lighthouse sign. Lighthouse sign, which is a sign of mastoiditis. Okay, it's called as lighthouse sign. It's pulsatile otoria. Okay, fine. Chalo. So this is about mastoiditis, what I wanted to tell you. What is this? Okay. So a patient had got hearing disability, and this patient could not undergo a hearing aid, a conventional hearing aid inside the canal hearing aid. Why? Because there was otitis externa. इस patient की otitis externa था. या let's say इसकी ear canal developed ही नहीं थी. Right? There was poor development of ear canal. So what can we rehabilitate this patient by? We can rehabilitate this patient by, very rightly said by all of you, by something called as BAHA, or which is also called as bone anchored hearing aid. So what you can see here, this is bone anchored hearing aid, which is present over the bone. We have kept it over the body of the mastoid, just above it. Right? So this is called as BAHA. BAHA has got three components. One is called as abutment screw, which is made up of titanium. Center one is called as an abutment. Third one is called as speech processor. So there is a speech processor which attaches to the abutment. Abutment attaches to the screw, or the abutment screw, which is made up of titanium. So we usually do BAHA in two stages. In the first stage, what do? We drill the skull and we fix this titanium screw. इसके अंदर हम screw लगा देते हैं. Okay? And what do? We wait for around 3 to 4 months till this screw undergoes osseointegration. There's a process called as osseointegration in which the bone will accept the screw. So once the bone will accept the screw, after 4 months, what will we do? We will attach this abutment to the screw, and above that we will attach this speech processor. So what will happen? The speech processor will catch all the sound and it will amplify it and send it directly to the inner ear for the person to hear. That is bone anchored hearing aid, because bone conduction is being conducted by this particular aid. Now this is usually given in those cases where we cannot use air conduction hearing aid. जैसे canal atresia, right? Or poorly developed ear canal, poorly developed pinna. Or patient is having chronic otitis media, or the patient is having chronic otitis externa, where we cannot give, right? In all these cases, these patients are warranted for BAHA. Okay, fine. Chalo. Now, two important incisions as far as ear surgery is concerned. One incision is given in all types of myringoplasty, all types of tympanoplasty, all types of stapes surgery, सब में देते हैं. And this incision is an endomeatal incision, मतलब meatus के अंदर देते हैं, in the bony canal skin. And we give this incision 5 millimeters away from the annulus. See, this is the tympanic membrane. We give it 5 millimeters away from the annulus. And this is the bony canal. This is the canal, right? This is the canal. This is the bony canal in which we are giving this incision. 5 millimeters away from the annulus. And this is 6 o'clock position. This is 12 o'clock position. So we give an incision from 6 o'clock till 12 o'clock position. What is this inside the canal incision called as? This incision is primarily called as Rosen's incision. Rosen's incision. What is Rosen's incision? Rosen's incision is given inside the bony canal, 5 millimeters away from the annulus in all ear surgeries, wherever we have to come inside into the middle ear. So basically, we are going to raise the skin of the bony canal together with the tympanic membrane, and we are going to raise it like a flap, which is called as tympanomeatal flap. See, meatus skin is like this. This is the tympanum, middle ear. So हम पूरी इस layer को उठा देंगे. And we are going to inspect and do things inside the middle ear, and then we are going to keep this back. This is what is called as a tympanomeatal flap. So for raising a tympanomeatal flap, what incision do we give? We give a Rosen's incision, which is inside our bony canal. And this is given from 6 o'clock to 12 o'clock position. Okay, curvilinear. Right? Now, if we are doing any post-auricular approach, doing any surgery from outside post-auricular area, we give an incision in the post-auricular groove, and that incision, which is given behind the ear, you can see this is the pinna, the incision given behind the ear for post-auricular approach, this incision is called as William-Wilde incision. So what is William-Wilde incision? It is a post-auricular incision for doing any ear surgery. If you want to raise a tympanomeatal flap and go inside into the middle ear, we give Rosen's incision, 6 o'clock and 12 o'clock, and curvilinear incision. Okay, fine. So these are the two incisions that you should remember as far as ear surgeries are concerned. Okay, chalo. Now, you have got a child, 1 year old, and this child has got hearing loss. You inspect the child, and you see a pearly white mass behind a fairly normal tympanic membrane. You can see this is a normal tympanic membrane. Cone of light bhi hai. Sab kuch acha dikh raha hai. But what do you see over here? You see a pearly white mass behind tympanic membrane. Also, you notice that the pars flaccida is normal. You also notice that the pars tensa is normal. You also don't have no history of prior otorrhea or perforation. There's no history of any otorrhea, ear discharge, perforation, or even ear surgery. Nothing has been done. No prior history of otorrhea, perforation, ear surgery, pars tensa normal, pars flaccida normal, pearly white mass behind the tympanic membrane. What is this diagnosis? Okay, Gayatri, we do Lempert's incision. I'll tell you what is Lempert's incision. Just after this, I'll tell you what is Lempert's incision. Okay. So what is this diagnosis? Pearly white mass behind the normal tympanic membrane, normal pars flaccida, normal pars tensa, no prior history of otorrhea, no discharge, no perforation, no ear surgery being done. What is this? This is congenital cholesteatoma. Congenital cholesteatoma. Always remember, whenever you get such scenarios, 1 year old child, 2 year old child, maybe 3, 4 year old child, you do an examination, you see this pearly white mass, and you see all of these things. Pars flaccida normal, pars tensa normal, pearly white mass behind the TM, and no history of prior surgery, otorrhea, or perforation. This criteria is all these points is called as Levenson's criteria. Levenson's criteria, which has got all of these points written in it. So that's why I told you in this example, this is how it will be. So this is a classical example for congenital cholesteatoma. Remember that. Okay. Now, let me just finish what Gayatri told. Gayatri asked me what is Lempert's incision. Lempert means there are two incisions, Lempert 1 and Lempert 2. Lempert 1 is same as Rosen's. 6 o'clock to 12 o'clock inside the bony cartilaginous junction. If we get that incision out through the incisura terminalis is a space between your tragus and the crus of helix. If you get it out through the incisura terminalis upwards, we call it Lempert 2. So Lempert 1 is 6 o'clock to 12 o'clock curvilinear incision. Lempert 2 is extension of the Lempert's 1 out through the incisura terminalis upwards. We do Lempert's incision, basically Lempert's 2 in those cases where we want to expand the ear canal. Because if we give a cut through the incisura, the canal can get a little wider. So if there is a little space or a lesser space for us to do things inside the ear and operate, we give Lempert's incision. And we continue that Lempert's 1 together with the Lempert's 2 out so that we can expand the ear canal and we can get a much wider space to work. Did you understand now? What is 1 and 2? Right? And what are these incisions? And what is congenital cholesteatoma that I told you? Okay, fine. Chalo. Now let's come to the next one. Okay, this is almost like I'm just left with 2-3 things. Now this is a diabetic patient. This is a patient who is diabetic. And this patient developed profuse ear pain. Or basically this ear pain was mostly in the night. So we can say this was nocturnal otalgia with purulent discharge, which was purulent blood-tinged ear discharge and hearing loss. On examination, you saw that there is granulations which are present at the bony cartilaginous junction. Bony cartilaginous junction pe there are granulations. Diabetic person and has discharge, hearing loss and nocturnal otalgia. Yes, this is malignant otitis externa. Aankh band karke wherever you see granulations, external auditory canal and diabetes, this is malignant otitis externa or MOE. Okay, remember that. So the answer is malignant otitis externa. The other name is necrotizing otitis externa. The other name is skull base osteomyelitis. All of these basically mean the same. Okay. Now, what questions they will ask you? Most common cause is Pseudomonas aeruginosa. Most common cause is Pseudomonas. It can happen by fungal also, Aspergillus fumigatus, but more common is Pseudomonas. Most common people who get it, diabetics and immunosuppressants, right? Or on immunosuppressants. Now, what is the staging for malignant otitis externa? Okay, so there are 4 stages for malignant otitis externa and they are very, very simple. If the malignant otitis externa is only involving soft tissues, we call it stage 1. Okay, if it involves soft tissues of the external auditory canal plus bone, that means here the technetium 99 scan will become positive. Technetium 99 scan is a scan which we do in malignant otitis externa to check for bony involvement. It is a radio tracer which goes and shines at the areas where there is osteomyelitis going on. Okay, or where there is necrosis going on. So if the bone is involved, technetium 99 will be positive. Stage 1, technetium 99 will be negative. So soft tissue plus bone, that is stage 2. 3 is divided into 3A. That is single cranial nerve palsy. Most common cranial nerve to get involved in malignant otitis externa, facial nerve palsy. If there is 3B, multiple cranial nerve palsy, that means it has gone way beyond and involved the base of skull. That is why multiple paralysis of cranial nerves have come. And stage 4 means the patient has ended up with meningitis or empyema, or there is sinus thrombosis. So these are the 4 stages of malignant otitis externa. Remember this. What is the investigation of choice to do to check for bone involvement? Technetium 99 bone scan. Okay. What are the radiological techniques to check for whether your patient is becoming better or not, or whether your treatment is working or not? So in follow-up, what investigations do you do? So on follow-up, we usually do gallium scans, gallium 67 scans. So initially we do technetium 99. On follow-up, we do gallium 67 scans. Okay, fine. Even we do ESR and CRP levels. ESR and CRP also tell us whether the patient is becoming better with our treatment or not. Because we'll give antibiotics. If we see ESR and CRP falling, that means inflammation is coming down because they are acute phase reactants. Right? What is the drug of choice? I told you wherever Pseudomonas is there, think ciprofloxacin. So the drug of choice for this particular Condition is also ciprofloxacin. Drug of choice, ciprofloxacin. If the patient is resistant to ciprofloxacin, then ceftazidime. Ceftazidime. And they both have to be given for around 6 to 8 weeks. Long treatment goes on. Almost 1.5 to 2 months you have to give antibiotics. Because this is a very dangerous disease. 50% mortality is there. Right? Now, if suppose your treatment is not working, then the surgical line of management is waited till the end. It is not the first one we do surgical management. We wait till the end. If the medical management fails, surgery is by subtotal petrosectomy. Subtotal petrosectomy. That means almost complete removal of the petrous part of temporal bone together with all the mastoid and everything is removed. That is called a subtotal petrosectomy. That is a very radical surgery. That is why we wait till the last. But before that, we have to complete the medical line of management. Okay? These are the ones that are asked as questions as far as malignant otitis externa is concerned. Okay? Chalo. Okay, I know you guys must be tired now. So almost I'm done. And the last two segments are left now. Last two images are left. Okay. Now something related to surgeries. So let's say this is something what I've done, a cortical mastoidectomy. Okay. So this is something what we have done, a cortical mastoidectomy. Now we have completed a cortical mastoidectomy. What is cortical mastoidectomy? Exentration of all the accessible mastoid air cells. Right. We have removed all the mastoid air cells. Now inside the mastoid cavity, there are some things which I want you all to remember and to visualize so that you can answer. Okay. Now, whenever we open the whole mastoid cavity, right, this is the mastoid tip, and imagine this patient is lying down. Imagine me lying down like this. So you are seeing my right side of the ear like this. Okay. So this is my superior, this is my inferior, this is the tip, this is the superior end, this is my anterior, and this is posterior. Right? This is the orientation of me lying down when I did a whole drilling of the mastoid. Right? Now, when I drilled the mastoid, anteriorly, what will I have? This is my ear canal. See, this is my ear canal. So if this is my ear canal, this is my posterior canal. This is my anterior canal. Correct? This is my superior, this is my inferior canal. So that is why if we drill the mastoid and if we keep this posterior canal wall standing and intact, we call it as canal wall up mastoidectomy. If we take this down and we drill it also, that is called as canal wall down mastoidectomy. And you know the example of canal wall up mastoidectomy is cortical mastoidectomy. And canal wall down mastoidectomy is modified radical mastoidectomy and radical mastoidectomy. Correct? They are more radical. That is why we take down this canal. Correct? This is the tip of mastoid. This is superior. Now, what are the limits of cortical mastoidectomy? What are the limits? Till what do we drill? We will first find the largest air cell of mastoid. And the largest air cell of mastoid is what? See, let's say this is your mastoid, right? And this is your canal. This is superior. This is posterior. This is inferior. This is my posterior canal. Okay. Now, when I start doing cortical mastoidectomy, first I will do what? I'll identify an elevation which is present in my posterior canal wall. Okay, there is an elevation. If you see here, this is an elevation which is present in the posterior canal wall. And this elevation that is present in the posterior canal wall is called as spine of Henle. It's called as spine of Henle. Okay, it's called as spine of Henle. Fine? Okay, this much we have understood. Now, remember, we draw an imaginary triangle when we do cortical mastoidectomy. If we draw one imaginary line along the posterior canal wall, okay, another imaginary line along a line which is called as inferior temporal line. So this line over here, this is our inferior temporal line. This is the area where my temporalis muscle is attaching. So that's why it's called as inferior temporal line. So this is the inferior temporal line. Anteriorly, we draw an imaginary line along the posterior canal wall and a tangent joining the two. This is a tangent which joins the two. I get a triangle. And this triangle in which we drill, this is called as McEwan's triangle. McEwan's triangle. Okay? Right? Now, I'll always have to trust this spine of Henle in order to find my mastoid antrum. Because mastoid antrum is the largest air cell of mastoid. And that is always constant. So now, if I drill posterior to the spine of Henle, 1.5 centimeters deep, because this whole cortex of the mastoid is 1.5 centimeter thick. So if I just behind the spine of Henle drill 1.5 centimeters deep, I will find the largest air cell of mastoid, which is my mastoid antrum. Okay, fine. Now, if I keep drilling towards this inferior temporal line, I'll reach a point where I'll see a kind of a pinkish discoloration. And this is my superior limit of mastoidectomy. And we call this plate as dural plate. We call this as dural plate. Dural plate ka matlab, there is dura, right? There's a plate of bone which is coming between my mastoid and middle cranial fossa. If I go above this dural plate, I'll enter inside into the brain. So can you see this area? This is my dural plate. Okay. Now, I'll drill posteriorly also. And when I drill posteriorly, I'll see something blue coming up. And this plate is called as sigmoid sinus plate. Sigmoid sinus plate. So my posterior limit of mastoidectomy is this blue colored elevation here. This is my sigmoid sinus, which is running over like this here. This is my sigmoid sinus, which comes down to form the internal jugular vein through the jugular foramen. So I'll find behind my sigmoid sinus. So the superior limit of mastoidectomy is dural plate. Posterior limit is the sinus plate. And the angle formed between the two is called as sinodural angle. And the other name for this sinodural angle is called as Sittely's angle. You also call it Sittely's angle. So see, this is sinus plate, this is dural plate. So what is this? This is my sinodural angle. Simple, right? This is also called as Sittely's angle. Okay, now what we'll do? Now once we identify these plates, we identify the antrum, we are going to exenterate out all the air cells. हम सब कुछ हटाएंगे. Okay, all these air cells we are going to exenterate out. हम सब हटा देंगे. Okay, and we'll enlarge the mastoid antrum, keeping in mind that we stay between these plates. Okay, we are going to remove everything. Now, the more important structure is that as soon as we open the antrum and we expand it out, medial to the antrum, I will find an ivory colored bone. Ivory colored bone. See, mastoid is a game of colors. So as soon as I drill, can you see this elevation over here? This ivory colored bone. So I have the antrum was like this. I drilled out. I saw this ivory colored bone medial to the antrum. So medial to the antrum will be which bone? It will be the lateral semicircular canal. Now, why have I drawn this lateral semicircular canal like this? It should be like this, right? Simple. See, lateral canal is like this. It's coming out. It's coming out. If I sleep, it becomes straight. Simple. So that is why it has become vertical. So it has become vertical. Why? Because I'm sleeping. So that is why this bulge is the lateral semicircular canal, which is my medial limit of cortical mastoidectomy. Okay, fine. So this is my horizontal canal. These are the limits of cortical mastoidectomy. So what are the limits? Anteriorly, posterior canal wall. Posteriorly, sigmoid sinus. Inferiorly, the tip of mastoid. Superiorly, the dural plate. And medially, the lateral semicircular canal, which is ivory white in color. Okay, fine. Now, one important part that I want to add, that your facial nerve is actually running like this. Your vertical part of facial nerve is running like this and it is going inside. Okay, it's going inside because you see, this is your tympanic membrane. So it's running down like this. So vertical segment of the facial nerve is the one which runs inside the mastoid. And this is the segment which undergoes iatrogenic injury. Okay, now, if you see that the facial nerve is actually turning medial to the lateral canal. Medial to the lateral canal, this facial nerve is turning. And this area where the facial nerve turns, this is called as second genu. Now let me ask you a very important question. Which is the commonest site for facial nerve injury? In mastoidectomy, it is second genu. Second genu of the vertical segment is the most common area for facial nerve injury, which is medial to the lateral canal. So whenever we are resecting out, this is the common area where we snap out. Okay? So remember these important points. Okay, what I told you. Right? Chalo. Now, this is what you have understood. Now, let me just give you another example. This facial nerve is running as a vertical segment down. It gives off an important nerve which enters into the ear. And this nerve is called as chorda tympani. Okay, this is called as chorda tympani, which is the nerve of the vertical segment of facial nerve, which enters into the ear. Can you see this space between the chorda and the facial? This space is called as facial recess. So the space between the chorda and the facial nerve, this is called as facial recess. This is called as facial recess. Okay. So chorda is given out. from the facial, and the space present between the chorda and facial, that's called as facial recess. And facial recess is the one that I want to show you now, because now you have understood about the basic cortical. See, this is the canal, lateral canal. This is the superior, the dural plate. This is sigmoid sinus. This is sinodural angle. This is the tip, right? Now, if I just focus on this area, over on this image, and I show you, see, this is your facial nerve running. Okay, let's say this is a facial nerve, and this is the chorda, right? This is the chorda. Okay, so between the facial and chorda, if I drill, right, I'll do something called as a facial recess approach. The space between them is called as facial recess. And this is called as facial recess approach. The other name for facial recess approach is also called as posterior tympanotomy. It is also called as posterior tympanotomy. Now, why do I do this? It's because if I drill this part, facial recess, I'll directly, access myself inside the area of the middle ear, which has the round window. So I can directly see the round window. You can see the round window through this facial recess. So what can I do through this approach? If I do a facial recess approach between the chorda as well as the facial, I can directly see the round window. And this is a common way in which we do cochlear implant surgery. So we can directly take a cochlear implant and put through the round window, and that cochlear implant will straight away go into the scala tympani. Now see this question. Both questions are asked. What is the cochlear implant electrode put through? Round window. How it is put? Facial recess approach. Into what? Scala tympani. It will directly go into the scala tympani. That means the electrodes will rest into the scala tympani. That's called as posterior tympanotomy or facial recess approach. Okay, so I hope you guys have understood about these basic questions, because they can be asked. They are very commonly asked in your exams, and especially cochlear implant, they are asked all three questions. They've asked facial recess, they've asked posterior tympanotomy, they've asked round window, they've asked scala tympani. Okay, so remember this line that I told you. Okay, chalo. Last question and the last surgery. I know that you guys must be tired now, because I am also exhausted now with a lot of ENT. This was a crash course that we finally had of the whole of ENT, right from the larynx till the ear. Okay? Yes, that is right, Gayatri. So whatever you have written, this is what I told, right? Okay. Final image. What is this surgery, right? Now this is particularly called as stapes surgery, what I discussed with you, and this is called as stapedotomy. Stapedotomy, right? So stapedotomy mein hum karte kya hai? They have asked what you have put here. Okay, what you have put here. So see, we have removed the stapes because stapes was not working, it was fixed. This is the footplate of stapes, and this is the incus. Now between the incus and the stapes, we need to put something, because the stapes suprastructure is not there. So what do we put? We put a piston. And this piston has been asked as a question. What is it called? This is called as a Teflon piston. This is called as Teflon piston. So it actually looks like this. Okay, it actually looks like this. And we hang this piston from the long process of incus down to the footplate of stapes, so that when the incus moves, the piston also moves. Okay, so this is a very common thing that we use as a processes in stapes surgery or in stapedotomy. Okay. Now, a question इसमें सबसे common जो आता है stapes में, what is one nerve that can get injured in stapedotomy? और वो nerve का reflection यहाँ पे दिख भी रहा है. Right? What is one nerve, commonest nerve which can get damaged in stapedotomy? And this nerve, I told you just now, that nerve, it is chorda tympani. Chorda tympani. Chorda tympani is the most common nerve which comes into the ear through that posterior wall, and whenever we are in the posterior superior quadrant, this nerve is going to get encountered, and that is the reason why it commonly gets injured in cases of stapedotomy. Okay? So this is all about your crash course of ENT, and I hope you guys have understood, right? Yes, last INI, they gave a schematic diagram of stapedotomy and you got confused. Yes, so remember, stapedectomy is complete removal of the stapes, right? Sab kuch hata denge, and they'll put a prosthesis. Stapedotomy, they will save. Stapedotomy, they will save the footplate of the stapes. They'll not remove it, and they'll put this Teflon piston. Right? Chalo. I hope you guys have enjoyed it. You've been very active. And it's late night, and I'm very happy that you guys have been actively participating all throughout in this segment. Are there any questions for you guys to put in? I'll be very happy to answer. If you don't, then also if you get anything, you can put it on YouTube. I'll come back, I'll see those questions and I'll answer it for you. But this is kind of a crash course. I hope you guys have got a lot of things from this, and many questions will get. I'm telling you, just watch the radiological segment also, what I have shot for in the previous class. and that radiology will help you. There are 20 important scans which I have discussed. So thank you so much for all of you for attending today's session, and all the very best for your INI-CET as well as coming NEET PG exams. You guys will really rock it. Okay? So be calm, be composed, and ace your exams. Thank you so much. Thank you. Good night.